Hello, good afternoon, and welcome. Thank you very much for coming to the summit today. My name is Hannah Searing, and I am the Director of Research and Evaluation within the Bureau of Maternal, Infant, and Reproductive Health in the New York City Department of Health and Mental Hygiene. I'm also the Director of the Severe Maternal Morbidity Project that we will be discussing today, and the co-chair of the Maternal Mortality and Morbidity Review Committee for New York City. We invite you here today to learn about what we have discovered and uncovered through the Severe Maternal Morbidity Project from the persons who implemented it and participated in it. I have placed my email on this slide, and I welcome you to contact me after the meeting with any questions or feedback you may have. Before we get started, I'd like to mention a few points of housekeeping. First off, this event is very childcare friendly and pet friendly. We recognize that presenters and participants are joining us from many different spaces. Please don't worry if your kids or pets or others end up on the camera. Let's all just smile and breathe and know that this is the reality these days and that it is all okay. Please be aware that we'll be speaking in detail today about physically and emotionally traumatic experiences related to childbirth, racism, and discrimination, which may be difficult or triggering for you. We're glad you're with us today. And we want to remind you to please take care of yourself. If you need to leave and would like to return at another time, at any point, this event will be recorded and shared later. In addition, we will be offering a virtual safe space at the end of today's program, led by one of our sister organizations, the Spirit of a Woman Leadership Development Institute. This will be a virtual space, or red tent, as it is called, for participants who wish to end the day together, to share stories and release any lingering emotions that came up throughout the day. More information about this will be given closer to the end of today's program. We will also have the chat box open throughout the summit today. Through the chat box, I encourage you to connect with one another around this work. We will be monitoring it periodically, and if there are any unsafe interactions, we will have to shut it off. We will also have the question and answer function on during our panel presentations today. It is the Q&A function on your screen at the bottom. I encourage you to use this function as we want to hear from you. During the panels, I will be monitoring the Q&A box and collating questions, which I will then share with the panelists and moderators and invite them to respond. As a reminder, this event is being recorded and will be shared via email to all registrants in the upcoming week. Although this webinar does not have closed captioning today, we will be sharing our recording through YouTube, which has an accessible closed captioning feature. Finally, we invite you to share your thoughts about the event on Twitter or other social media platforms. The hashtag for today's event is hashtag NYC Health Summit. As we begin today, we first want to acknowledge recent events and how they impact maternal health, particularly for Black women and women of color. During the past several months, we have seen a surge of Black Lives Matter protests around the country, calling for an end to police brutality and structural racism. We can see the impact of structural racism on maternity care, in which Black women and other women of color often have unequal access to respectful, high-quality care, which contributes to the racial inequities we see in maternal health outcomes. Emerging data on the impact of the COVID-19 pandemic on maternal outcomes and lived experience suggests that COVID-19 has further increased these inequities. In New York City, since the beginning of the pandemic, we have witnessed the deaths of multiple Black women during childbirth, including Amber Rose Isaac and Asia Washington. In both cases, the families publicly spoke of how these women were mistreated. And we have even more, many more tragic cases of maternal deaths previous to COVID, including the passing of Shamini Makeba Gibson, who was the daughter of Ms. Shawnee Benton Gibson, who will speak to us later today. So before we begin, we would like to dedicate this day to all the mothers who have experienced a severe maternal morbidity and families of mothers who have lost their lives to a pregnancy-related death, most especially from those communities of Black and Brown families who suffer the disproportionate share of this epidemic. Please join me now in taking a moment of silence in their memory and in their strength. Thank you. Today, we will discuss the models, tools, and approaches that the New York City Department of Health and Mental Hygiene implemented under the Severe Maternal Morbidity, or SMM Project, which was funded by Merck for Mothers in partnership with the Fund for Public Health of New York City. We'll first hear a welcome from two leaders in our field, followed by an overview of New York City data. We'll then turn to a series of 3 panels. Our first panel is composed of hospital staff who participated in this project. They will discuss the results and lessons learned from reviewing severe maternal morbidity cases in 3 hospitals. Our second panel discusses results of interviews with mothers who experienced a severe maternal morbidity or severe complication in childbirth. And our third panel explores how we piloted new ways to engage with the community around data and educate them about warning signs of severe maternal morbidity. We will end the day with a call to action led by another leader and advocate in our field, Ms. Shawnee Benton Gibson, who will lead us in a call to action. And we'll conclude with a virtual safe space for participants to share their stories and release emotions. Let us begin. Today, we are lucky enough to have Dr. Daniel Stevens join us. Dr. Stevens, if you would please turn on your video and mic. Dr. Stevens is the Deputy Commissioner of the Family and Child Health Division of the New York City Department of Health and Mental Hygiene. We invited him to give us a picture, give us a picture and provide us with his thoughts on the importance of addressing the inequities in maternal health outcomes, and to speak broadly about the big picture of what the health department is doing to address these inequities. Dr. Stevens earned his MD from Columbia University and a BA from Harvard. He is a pediatrician and public health leader with a record for advancing equity in government, nonprofits, academic, and community pediatrics. He currently leads the health department's Family and Child Health Division, as well as coordinating our public health crisis in response to COVID-19, with a focus on support to the schools in New York City. Prior to coming to the health department, Dr. Stevens served as the Vice President of Health and Wellness for the Children's Aid Society and as a pediatrician at Harlem Hospital, Columbia University Medical Center. He brings a wealth of public health and clinical experience, and I'm pleased to provide him to you with welcoming remarks. Thank you.
Thank you very much, Hannah. Can you hear me? I hope so. Good morning. Okay, great. Good morning, everyone, and thank you for joining us today. I'm very pleased to join you. I'd like to start by thanking the Commissioner of the New York City Health Department, Dr. Choksi, for his steadfast efforts and leadership of the department in our movement to reduce maternal mortality and severe maternal morbidity, and to eliminate the racial and ethnic disparities and inequities that we see within the city. As I'm sure you'll all agree, becoming a mother should be a healthy and happy time for all women and their families. But for too many, it's a time of loss. And to be frank, we have too many women walking into hospitals and not leaving them. This is something that has gripped us all, and we have seen this data, and we have heard these stories far too many times. Nationwide, Black women are 4 times more likely to die from a pregnancy-related issue or complication than white women. And in New York, that inequity or discrepancy is even greater, where Black women are 8 times more likely to die as a result of pregnancy than white women. And as you've already heard, structural and institutional racism are the driving forces, root causes behind these unacceptable data. You know, Black and brown women have long endured physical and sexual violence, reproductive coercion, medical experimentation in our country. This painful and violent history, while reverberates across generations, it must be acknowledged and confronted if we're to eliminate disparities in maternal health. And today, I speak as part of the Department of Health, leading the Family and Child Health Division, and supporting our Bureau of Maternal, Infant, and Reproductive Health. We are city government, and so we have to acknowledge both our role and in calling out the history of violence against Black and brown women. A critical step towards narrowing this gap that we're seeing seems deceptively simple, right? Why can't we just listen to and trust Black and brown women? There are all too many examples of names that we know, from Serena Williams to some of the names that we don't know, because these life-threatening birth experiences either aren't reported, or Black women aren't heard or listened to when they are reporting symptoms, pain, complications. We have to ask ourselves, what is it that is preventing Black and brown women from being seen, heard, respected, and treated the way that we know all women deserve to be, both around childbirth and well before? I know that when we think about the stories that we've heard, it concerns us all, that we are also thinking about the stories that we haven't heard, and the women that we've lost or that we've come near to losing, and the work we have to do better by these women, for our families, our communities, and for our entire city. When we think about our city, we have a great many resources, and we are tasked with not only calling out this inequity, but we have to do the work to pull together those resources to reduce that same inequity. Racism occurs at multiple levels, right? The challenge ahead of us is rooted in hundreds of years of racist practices, institutions, assumptions. And we have to start by acknowledging the ongoing breadth of the impact of systemic and ongoing racism. It affects everything from our housing to our schooling to, yes, our health outcomes, but it is much broader. And I think it's important to acknowledge that as we take this on, to understand the fight and what we're up against. I say that to say I am here hopeful, I am here energized, and I am here joined by colleagues at the health department who are in this work and are committed to reducing these inequities. It's not easy, but we have a lot of work to do. And I want to thank everyone here in their partnership to continue this extremely critical work. This is our #1 priority in our bureau, in our entire division. As a health department, we will continue to focus on this fight. And I thank everyone for their time and hope that you get a lot out of and benefit from today's convening. Thank you.
Great. Thank you so much, Dr. Stevens. I would like to invite Dr. Etibet to come up, and I would like to invite Sarah Kremer, if you could turn on your video and introduce Dr. Etibet. My computer, personal computer is down. Thank you.
Hi, sure, I'm happy to do that. Thanks, Hannah. And thank you, Dr. Stevens. We'd like to acknowledge Merck for Mothers for their generous support of the SMM Project. And now I'd like to introduce Dr. Mary Ann Etibet, who serves as the Executive Director of Merck for Mothers. Dr. Etibet earned her MD and MBA from Yale University. She's an infectious disease physician, researcher, and powerful advocate for women's health and health equity, with extensive experience in the national and global arena in healthcare strategy, health system strengthening, and performance improvement in the private, public, and nonprofit sectors. As the Executive Director of Merck for Mothers, Dr. Etibet is responsible for Merck's $500 million global commitment that is focused on improving the health and well-being of women during pregnancy and childbirth. Prior to joining Merck, Dr. Etibet served as a senior advisor on DSRIP and population health with the Greater New York Hospital Association, and was an attending physician and professor at Bellevue Hospital / NYU School of Medicine, and a director of ambulatory care at the NYC Health and Hospitals Corporation. Welcome, Dr. Etibet.
Wow. Thank you, Sarah, so much for that kind introduction. And thank you, Dr. Stevens, and to the team at the Fund for Public Health and the New York City Department of Health and Mental Hygiene for inviting me here today. And to all of you participating from wherever you are participating, from the honor of being able to share some of my reflections. When I first learned that I was speaking today, I asked Anna and the team, what they would like my remarks to focus on. And one of the things they said is that it would be interesting for me to reflect on how this unique, Merck for Mothers collaboration in New York City relates to some of the other work we are doing around the world to help end preventable maternal deaths. I have a slide deck I think will be coming on where you'll see we have collaborations in many countries, 48 and counting. And since 2011, these collaborations have resulted in over 11 million women reached through programs such as this that are supporting safe, high quality, and respectful care. But I'm pausing because the global and local aspect of our work is, for me, also personal. I first moved to Brooklyn about 25 years ago. I'm speaking from Brooklyn right now. Then I was starting out, the whole world was ahead of me. And it's where I met my husband. We would drive through the streets learning more about ourselves. And one day, as we were driving by one of the neighborhood hospitals, he shared with me the story of his brother and sister-in-law. They'd had a daughter and were pregnant with their second child. My husband was often the babysitter, whenever his sister had a doctor's appointment. And out of the blue one day, his brother called him to babysit again because his wife wasn't feeling well and he felt he needed to take her to the hospital. That day, they both walked into that hospital in Brooklyn. She about 36 weeks pregnant, but only he walked out. Our family comes from Nigeria, the country that contributes almost 1 in 4 global maternal deaths. But one of the things that they never expected to happen to them in the United States was a death from childbirth. But we all know, especially all of us on this call, that maternal deaths can happen when we least expect it, to anyone, anytime, anywhere. And due to the work of many, including here in New York City, who have shared their stories and have also looked at the data, we know that disparities in maternal health outcomes exist not only across nations, but within countries, states, and cities. Maternal mortality tracks the inequities and exposes the vulnerabilities in our society, and systemic racism, as Dr. Stevens mentioned, is a cause of the poor maternal health outcomes we see here in the United States. The United States is the only high-income country where maternal deaths are on the rise and where disparities in maternal health outcomes are also rising. Dr. Stevens mentioned, in New York City, women have almost an 8 times greater risk of pregnancy-related death than white women. And for every death, there are at least another 100 women who've experienced a severe maternal morbidity or life-threatening event. And those inequities and disparities are reflected also in severe maternal morbidity. So what have we learned from across all of our collaborations? If I could summarize in just 4 key things, they would be how to ask, listen, act, and learn. For example, when an organization called the White Ribbon Alliance asked 1.2 million women across the globe what they wanted, what they heard, the #1 demand from women: respectful and dignified care. These demands are universal for women across the globe, and it's the simplest, most revolutionary thing to do is ask women what they want. Dr. Stevens said, why can't we just listen? We need to do more of that. We need to encourage others to listen, like in our collaboration with the CDC on the Hear Her campaign, which has resulted in millions learning about the warning signs of pregnancy and birthing complications, as well as providing education for providers on how to respond when women tell them what is happening to their bodies. My husband still often asks me if there was something different he could have done. Why didn't he know that his sister-in-law may have been in trouble? Why didn't he know what to do? Why didn't her doctors know what to do? And so asking and listening is not enough. We also have to act on what we hear and support the creation of communities of purpose and action where we can learn from each other. And I am excited, so excited to hear the stories of action that will be shared today and to learn from them. Fast forward 25 years later from the story I told, and that girl, my niece, that was left motherless by her mother's death, still today has a higher chance of dying in childbirth than her own mother did. And so to end preventable maternal deaths, we must work together to create accountability for these principles of listening to women and having women voices and community voices, birthing people's voices at the center of all we do, so that they become new norms and dismantle the harmful institutional cultures and structures created by over decades of systemic racism. Our actions must lead to sustainable change, not just today, but for the future of our daughters and our granddaughters. And it is great to see and learn more about all of this in today's summit, and learn more about how indeed all of you are acting. And I look forward to having it inform the work we are doing across the globe. Welcome.
Thank you so much, Dr. Etebet. That was wonderful. And thank you, Dr. Stevens. Before we move into the day, I'd like to give a short presentation of data and end with a story. Each year, there are approximately 120,000 births in New York City. Of this total, each year in New York City, we lose approximately 25 to 30 mothers to a pregnancy-related death, or the death of a mother that occurs during pregnancy or within 1 year from the end of pregnancy, which is attributable to the pregnancy. Severe maternal morbidity, or SMM, are severe complications in childbirth where a mother almost loses her life. SMM are about 100 times more common than maternal death. As you can see in this slide, this means that in New York City each year, approximately 2,800 mothers suffer a near-death experience during childbirth, such as heavy bleeding, kidney failure, stroke, or heart attack. This is an epidemic, one which we must continue to address with all of our efforts. Next slide. We often talk about this work in urgent terms, and it is urgent. Yet I must also underscore that severe maternal morbidity is a rare event. Most women do not experience these events. Indeed, 95 out of 100 Black mothers will not experience one of these events. However, when they do, Black mothers experience them at a much higher rate than white mothers. This slide shows just how different the experiences of Black mothers are compared to other race ethnicities. When Black and brown women experience a serious complication during birth, they do so at a rate of 3 times that of white mothers. We know that education is often protective in regards to health outcomes. However, when we look at the data, we see that Black mothers with a college degree, doctors, lawyers, professors, have higher SMM rates than mothers of any other race or ethnicity who have not even graduated high school. The same holds true if we look at chronic disease. Black mothers with no chronic disease have higher rates of SMM than mothers of any other race who have at least one chronic condition. Even when we control for factors like chronic disease, age, and education in our research, we find that Black mothers are still more likely to suffer an SMM than white mothers. Why is this? Research shows that these outcomes are a result of unfair, unjust, racist systems that are baked into the United States. This is where we need to look for explaining these differences, rather than blaming individuals or naming race as an independent risk factor of poor outcomes. Why do I say this? As we begin our day, I would like to share some of my own birth story with you to help explain disparities in birth outcomes. At what clinicians call the geriatric age of 39, I had my first and only baby, a daughter who is now 13 years old. I was overjoyed to be pregnant, planned when I would become pregnant, had plenty of healthy foods throughout my pregnancy, had excellent health insurance, a family who supported my decision and pregnancy, a job that allowed me to take sick time for prenatal health care appointments, exciting childbirth classes, and an experienced obstetrician in my town who was warm and friendly towards me. There was a hospital 5 minutes from my house with state-of-the-art equipment and resources. I even had a child care center at my job to bring my newborn after I gave birth. Even with all of these privileges and care, I still suffered a severe maternal morbidity. In my story, I started feeling contractions early. At 37 weeks, I called my OB and went right to his office. He admitted me to the hospital immediately. He monitored my care throughout the night. When it was clear that I had preeclampsia, or dangerously high blood pressure, and both me and my baby were in distress, he performed a successful cesarean birth on me. I stayed in the hospital for 4 days and was healed within a week. That is my story, and it's a happy one. I had a highly competent OBGYN whom I trusted implicitly. When he said, "What is your birth plan?" I said, "For me and my baby to survive." And I meant it. And I trusted him to save us both, and he did. Tragically and unfairly, all women do not have the same privileges and access to healthcare and resources that I had. They are not listened to when they express concerns, and they don't have safety nets or families to catch them when they fall, nor do they have jobs that will give them time off, regular work schedules, and certainly not childcare in the office. Worse, some have none of these privileges, and they spend their lives battling racism on a daily basis, which in turn, research tells us, creates internal stress on the body's ability to function and ultimately can result in life-threatening complications for them and their babies. Some live in neighborhoods that lack resources and access to safe parks and playgrounds, accessible grocery stores, gyms. Many are targeted by the police and social service agencies or others who use racist structures to harass and jail them. All these factors result in weakening and aging mothers' bodies before they even get pregnant, resulting in chronic conditions such as diabetes and hypertension that make them 3 times as likely to suffer a maternal morbidity or even death. These inequities are outrageous and unfair. As we move throughout the day, I'd like to ask this group to think about what advantages each of us have. What role does racism play in the lives of people in our community that results in these inequities and outcomes? How can we come together to address this issue? What can each of us do to undo these injustices? We are eager to share our findings and our learnings with you, with the hope that you may find something today that is of use to you in your own work and lives. Finally, I want to pause and thank all the people who have come together over the past 3 years to implement this project. This includes the core Department of Health team, both past and present, our hospital partners who work tirelessly to save lives and improve their work based on experience and data, our storytelling partners who shared their stories with us, and our community partners who helped us get the word out about severe maternal morbidity, raise awareness of how to advocate for themselves, and to understand the warning signs of severe childbirth complications. You will hear from many of my colleagues and our partners today. However, there are several who I want to call out who won't have the opportunity to speak. 2 of those are Ms. Danielle Rivera and Ms. Maureen Clyde, who worked tirelessly behind the scenes to make today's event a success and to publish our Severe Maternal Morbidity Toolkit, which you will hear about in the next presentation. And 3 others who helped conceptualize and implement this work, but who have since moved on from the health department: Dr. Lorraine Boyd, Ms. Kelly Davis, and Ms. Emily White Johansson. So now I'd like to invite Ms. Sarah Kramer to come up and turn on her mic and camera. Ms. Kramer will now speak to us about the project, the Severe Maternal Morbidity Project. Ms. Kramer is the project coordinator for both the Severe Maternal Morbidity Project and for our New York City Maternal Mortality and Morbidity Review Committee. Ms. Kramer keeps us all in line and makes these 2 projects run smoothly and effectively. She's responsible for the day-to-day project management and is our main liaison with funders and partners. Sarah is also a social worker with her master's in social work from Columbia University and a BA from the University of Michigan. Before joining the health department, she worked at the Bronx Defenders, where she was the coordinator of the Healthy Mothers and Healthy Babies program and an advocate for families separated by the child welfare system. Ms. Kramer will now take you through our Severe Maternal Morbidity Project before we get to the panels led by the implementers of the work. Sarah?
Thank you, Hannah, for that introduction and for sharing your SMM experience with us. That was very powerful. And welcome, everyone. Thank you for joining us virtually. My name is Sarah Kramer, and I've had the distinct pleasure of coordinating the SMM project for the past 3 years. And for the next few minutes, I'll zoom out and introduce you to the project that is the basis for this summit. And before I do, I want to give a huge shout out to the research team behind the scenes who has been working for years to get to this point. I'm very honored to represent them and to represent our work. And our team's hope is to share this information in a way that is helpful to you, to your community, and ultimately to the people and the patients, clients that you serve. A quick but important reminder that an SMM event is a life-threatening complication during childbirth. Examples include a hemorrhage or other events that might lead somebody to the intensive care unit. We're centering SMM today because it is a social justice problem with health consequences. Its impact on thousands of New Yorkers, especially Black people and other people of color, is unacceptable and is widely recognized as preventable. The SMM project began in 2017 and it ends this month, and it's funded by Merck for Mothers. It was built off of previous work by the Department of Health that uncovered alarming results from looking at SMM data from 2008 to 2012. These results brought about numerous calls to action around maternal health, such as city council mandated reporting of maternal deaths and media reporting about the inequities in maternal health outcomes. It also brought about the realization that further study about SMM was needed. The goal of this SMM project was to work with clinical and community partners to improve maternal health outcomes, promote health equity, and reduce racial and ethnic disparities in SMM in New York City. And in the following slides, I'm going to speak very broadly about the project's key strategies. And I say broadly because this afternoon, each panel will do a deep dive into the implementation. Before we continue, I want to acknowledge that throughout the summit, you will hear presenters and panelists refer to birthing people, mothers, and women. And while most birthing people identify as women or as mothers, not all do. And while we might use these terms interchangeably, we want to make an intentional effort to be as inclusive as possible with our language choices today. Here we have a visual representation of the SMM project strategies and goal. We had many project partners and worked across interdisciplinary, clinical, and public health spaces. Over the past 3 years, the project shared information about maternal health with individuals and communities, interviewed people about their SMM experiences, and facilitated quality improvement reviews of SMM cases in local hospitals. This led to identifying opportunities to prevent life-threatening experiences and eventual implementation of those recommendations. This process ultimately brought us closer to our goal of improving maternal health outcomes, promoting health equity, and reducing racial and ethnic disparities in SMM. A similar case review process was also used by our Maternal Mortality Review Committee, which Dr. Stevens mentioned and will be discussed later today. The first project strategy that we'll discuss today was improving the quality of maternity care at hospitals. And just a brief reminder to stick around for panel 1 today, which will go into the nitty-gritty of the strategy's implementation. For now, broadly speaking, we operationalized the strategy by partnering with 3 New York City hospitals. We helped facilitate quality improvement, or QI, committee meetings to review SMM cases that happened in each hospital. The goal of the QI committee was to assess whether the SMM event was preventable and then propose recommendations to prevent similar events from happening in the future. A top priority was sustainability. We asked ourselves, how can we implement this project in a way that can be maintained once our project ends? First, we worked to understand each hospital's resources and limitations. Then we tried to meet the hospital team where they were at, learning about their process and helping them identify gaps and creative solutions. As you can imagine, providing resources such as an abstractor, to look at clinical records and coordinate meetings was essential, as was building an alliance with hospital leadership to prioritize SMM-focused efforts. And as was mentioned just a few minutes ago, in 2018, the Department of Health received funding to scale up this strategy. This effort is called the Maternity Hospital Quality Improvement Network, or the Network. And we consider the establishment of the network one of the great achievements stemming from the SMM project, and it will be covered more in depth during panel 1 today. The second project strategy we'll explore today is learning about the needs and experiences of those impacted by SMM. And this is our second panel this afternoon. It was important to us to center and elevate the voices of people who suffered a life-threatening complication during childbirth. We did this by interviewing people about their SMM experience and the myriad consequences in their lives. Operationally, this meant collaborating with experts to develop the process and tools. Given the highly sensitive nature of SMM, we carefully selected interviewers who had experience supporting pregnant and postpartum people using a trauma-informed lens. Also, it was important that we developed a list of local resources that participants could turn to for mental and physical health needs. We also gave this to participants in addition to an incentive in recognition for their time. This will be covered more during panel 2. And in the corner of this slide, you'll see our wonderful interviewers and research experts on the final day of the interviewer training in 2018. The third project strategy I'll touch on today is about community engagement. We used multiple approaches, which will be explored during panel 3 today. Broadly speaking, an important first step was developing consistent, accessible messaging around maternal health. We worked within our project team and across the health department to zero in on key messaging, data, and high-quality resources. One dissemination strategy was centered on the power of social media influencers. We used project funds to build contracts with 5 social media influencers. And a social media influencer is someone who has credibility with their followers, who are interested in emulating them, buying products they use, and trusting what they say. In our case, our partners have robust audiences of Black women and other women of color who may be thinking about starting families or navigating pregnancy and childbirth in New York City. These influencers shared posts on maternal health across their social media platforms, such as Facebook, Instagram, and their blogs. We also shared information through a Data to Action roadshow. This was a series of in-person presentations completed prior to the rise of COVID-19. Project staff traveled to community-based spaces to present information about maternal health complications to a diverse lay audience. We ended up facilitating over 20 unique presentations, reaching hundreds of people with these in-person presentations and subsequent discussions. And pictures from one presentation are in the bottom corner of your screen. Here you'll see the leaders of this strategy who both envisioned it and then brought it to life, and they are Kelly Davis and Hannah Empel. And our project's final data dissemination strategies include publishing a toolkit that lays out how to do a project like ours. And we're very happy to report that that is live and online, and you'll find the link in the chat box. And our project's final data dissemination strategy is publicly presenting our process and results at this Maternal Health Summit. And finally, I'd like to highlight the Maternal Mortality and Morbidity Review Committee, or the M3RC as we like to call it. The goal of the M3RC is to reduce preventable maternal deaths and eliminate inequities in these deaths. The way we do this is by first forming a committee comprised of local interdisciplinary experts. This group reviews each maternal death in New York City and strives to holistically understand each mother's journey. They determine whether her death was related to her pregnancy and whether it was preventable. They also brainstorm and propose recommendations for action to prevent future maternal deaths. The M3RC makes an intentional effort to use health equity and sexual and reproductive justice lenses. They are trained in implicit bias and use CDC-developed tools to explore how discrimination, bias, and structural racism could have impacted a mother's life and death. The M3RC also uses process and tools that are aligned with the SMM Project's hospital quality improvement strategy. Some members of the M3RC also worked on the SMM Project, and they'll speak about their experience during each of the panels today. And with that, I will turn it back over to Hannah to move us throughout the afternoon. Thank you for your interest in our project and for your work to improve maternal health outcomes. Please feel free to reach out by email.
Thank you very much, Sarah. Appreciate that. Thank you. So now we're going to go to our first panel. So I'd like to invite Dr. Cynthia Shahzad to come up. Dr. Shahzad is a MD and an OBGYN and maternal fetal medicine specialist. She is a professor emerita of obstetrics and gynecology and women's health at the Albert Einstein College of Medicine at Montefiore Medical Center, where she was formerly the vice chair of that department. She is currently a senior clinical advisor for maternal health in the Bureau of Maternal, Infant, and Reproductive Health in the Health Department. She co-chairs the Maternal Mortality and Morbidity Review Committee, and she co-chaired the ACOG District 2 Safe Motherhood Initiative from 2013 through 2019, and is the author of numerous publications on maternal health. Dr. Shahzad.
Thank you, Hannah. So in the next 45 minutes, we'll be hearing about one of the strategies of the SMM Project, namely saving lives through quality improvement and assurance at the hospital level. We engaged 3 pilot hospitals in this strategy. And in selecting these pilot hospitals, we considered the volume of deliveries in the SMM cases, the demographic diversity, the capacity to address SMM work, and also importantly, buy-in from hospital leadership to commit resources. At the onset of the project, each of the pilot hospitals differed in its existing QI review process. You will be hearing from leaders in our panel discussion, but first I'd like to give some background data to the project. This strategy consisted of using standard methodology of integrating SMM case review into hospital quality improvement committees with the purpose of identifying critical factors and implementing recommendations that would further avert future adverse outcomes. I will describe the step-by-step approach that was taken to achieve this goal. First, it all starts with case identification. We used a well-described, validated 2-item approach, identifying women who had been transfused 4 units or more of blood products and or were admitted to an intensive care unit during their birth hospitalization. After case identification, abstractors, typically nurses, midwives, or physicians who had maternity hospital experience, performed case abstraction. This included reviewing the hospital record and creating case narratives for QI committee members to review, and also the completion of a data abstraction form. This process was by far the most resource intensive. Next, hospital QI committees then reviewed each case and documented their decisions on a standard form. The SMM committee decision form was used, which was a modification of the CDC form that is used to review maternal deaths in New York City's M3RC, as well as by other states and jurisdictions nationwide. Components of the decision form include preventability, also expressed as, was there a chance to alter the outcome? Did she have to get as sick as she did? Additionally, what were the critical factors that contributed? What recommendations, if implemented, could have improved the outcome? The decision form was not new to the members of the pilot hospitals' QI committees. Each of the pilot hospitals had prior experience with use of the form as part of membership on New York City's M3RC. Completed case narratives and committee decision forms were then de-identified and sent securely to the jurisdiction, allowing for data to be aggregated. In this pilot, New York City DOHMH was the jurisdiction. However, other examples of jurisdictions could include state departments of health, centralized quality improvement committees for hospital systems, or a regional perinatal center. Finally, facilities develop and implement a plan to act on the recommendations, then audit results and report back to QI committees to close the loop. So what did we learn from undertaking this piece of the SMM project? The next slides are key lessons learned and a summary of our findings. As Sarah previously mentioned, a key success of this SMM project was the implementation of the SMM reviews into the existing QI committee structure of the pilot hospitals. But the success of this pilot really lies on its sustainability. And this is highlighted by the expansion of this strategy to 11 new maternity hospitals that comprise New York City's Maternity Hospital Quality Improvement Network. I will be referring to this as the MHQIN. Our 3 pilot hospitals are now part of this ongoing network. The data I will present are preliminary and reflect hospital-based reviews for 10 hospitals as of September 30th, 2020. Hospitals came to reviewing cases at different times of the year, and this was due to the known variability among the hospitals and the time it took to really get up and running. So this slide shows that 210 total cases have been abstracted at the 10 MHQIN hospitals, of which 89 came from our 3 pilot hospitals. Of those, 172 had gone through full QI review through the local hospital committees. 50 of those reviews were also from our 3 pilot hospitals. Hemorrhage was by far the leading type of SMM, comprising 81% of cases. Some of the hemorrhage cases also had ICU admissions. ICU admissions for non-hemorrhage related causes comprised only 19% of cases. This was true for both the pilot and the MHQIN facilities. Facility level QI committees found that about 1/3 of cases, there was either some chance or a good chance to alter the outcome. Again, this is expressed in, did she have to get as sick as she did? For example, maybe she would have only needed 2 units of blood instead of 4. It did not mean that the hemorrhage per se was preventable, but it suggested that critical factors contributing to SMM, if addressed by implementing the committee's recommendations, could have reduced the severity of the event. We also found common themes in the recommendations posited by the QI committees across 3 pilot hospitals. They were to improve clinical risk assessments and clinical decision-making, the adoption of facility-level policies to adhere to best practices, improving care coordination and facilitating earlier entry into prenatal care. Overall, I will reiterate that we accomplished our goals of using existing processes and resources to enable the development of sustainable SMM QI review at each facility. A cost analysis was also part of this project. We found that delivery hospitalizations with an SMM cost 1.5 times those without an SMM. You may be wondering, as we did, about the cost of this program. We found that the cost of implementing SMM review varied by the level of existing QI program and the amount of dedicated staff time needed to prepare cases. For example, in one hospital with a existing highly developed QI structure, utilizing an internal case abstractor who was familiar with the hospital's records, the cost was lower. 2 of our pilot hospitals were undergoing a change in their electronic health record systems. This contributed to higher costs during implementation. I'd like to just take a moment to feature the toolkit that was developed from this project. This is one of 4 volumes of the toolkit. It is a step-by-step detailed resource for implementing SMM review into the hospital QI program. You can find full details of the methods, and the cost analysis can also be found in the toolkit. It's now published online, and I believe the link is available in the chat box. So I've given you some background to the SMM QI process. Now we'll be moving forward to our panel discussion. The goal is to hear views and learn from the leaders of the pilot hospitals about integrating SMM review into their facilities QI process. What were the key strategies? What were the benefits? Was the process important? Was it worth the effort? Before we begin the panel, I would like to remind you all that this is a childcare and pet-friendly event, as Hannah had stated. We recognize that presenters and participants are joining us from different spaces with varying technologies, and we've certainly had our technology blips today. Please don't worry if there are technology difficulties or if someone extra comes into our space. Now I'd like to introduce our panelists. They're all very knowledgeable about the SMM review process, having worked as QI champions at our 3 pilot hospitals. I'll ask the panelists to please turn on their video cameras and unmute as I introduce them. First, Wendy Wilcox. Dr. Wilcox served as the chair of the New York State Task Force on Maternal Mortality and Disparate Racial Outcomes. She's the director of the Maternal Mortality Reduction Program for New York City Health and Hospitals, and is the chair of the Department of Obstetrics and Gynecology of New York City Health and Hospitals at Kings County. Dr. Wilcox is an obstetrician gynecologist by training. Next, we have Ms. Linda Brown. She is a dedicated registered nurse with more than 40 years of clinical and managerial experience. She has a master's of nursing administration and maintains her NCC certification in inpatient obstetrical nursing. Linda is newly retired after 18 years as a quality management coordinator for the obstetrical and neonatal services at Montefiore Medical Center. Our last panelist is Peter Wong. Dr. Peter Wong is the chair of the Quality Assurance Committee at Jamaica Hospital. He also serves as the Director of Performance Improvement for Obstetrics. Dr. Wong is an obstetrician gynecologist who was in private practice prior to joining Jamaica Hospital 3 years ago. So we will be answering your questions from those in attendance at the end of the panel discussion. You may type your questions into the Q&A feature of Zoom at any time during this presentation. Okay. We can have the slides off, and we're going to start our panel discussion. Hi. So we'll start off by asking each of the panelists their experiences about implementation of SMM into peer review. So maybe we'll start with Wendy. At the department level, what were your most useful strategies for implementing and integrating these SMM cases into your peer review process? Wendy, you're muted. I can't hear you. We still can't hear you, Wendy. Check that your mic, go to the mute button and check that your mic is connected. Go to the caret on your mic, on the mic button at the bottom.
Can you hear me now?
Now we can hear you. Terrific, thank you.
Great, thank you. New technology.
Oh yeah.
Good afternoon, everyone. Good afternoon. Dr. Shizat and fellow panelists, thank you so much for asking that question. So in terms of how did we integrate SMM cases into our peer review process, there were several steps that we took. First of all, it was really important for us to start with a multidisciplinary group. Often when we're thinking, how do we review cases in our department, we think of our OBs and perhaps some nursing, but it's also really important to think of the group as a wider audience, including perhaps our anesthesia colleagues, midwives, social workers, whoever else is important to the process. We looked for trends throughout our department. One example of that was when TXA became more widely used and was promoted by ACOG as for use in these issues. We looked and we noticed that people weren't exactly using it as much as they should have. And then we started our communication strategy, which was at department meetings, certainly at rounds, and also following up with individuals. We really found that individual feedback was really helpful and necessary to really get the ball rolling.
Thank you, Wendy. Peter, at your place, what were some of the challenges you faced in implementing the reviews? You're muted, Peter. Peter, you have to unmute. Peter, you're muted. I don't know if you can hear me. Okay. You're still not, we still can't hear you. Go to the mute button in the lower left corner and hit your choice.
Can you hear me now?
Now we can hear you. Terrific.
Oh, sorry. I think it was
you.
the mic on the actual speakerphone. So thank you for having us, having me on as a panelist. So at Jamaica, actually, we had to do quite a bit of change because we actually started from the ground up. Before the SMM review committee came on, we were doing intra-department reviews where we would have do the case abstractions and would present in a much smaller setting. And then so after the Department of Health came and said we're part of this collaboration, I think one of the big change that came was when you came in with a bunch of leaders and met with a big team. We had an isolated room in one of our private rooms that we can meet, and we had a big powwow with the administrators and administrations and a lot of our chairs from anesthesia, and we're able to get the ball rolling. And I think that was probably one of the biggest help we got from the Department of Health to get, push it forward. Again, I can echo what Wendy said is part of the transition was getting to a multidisciplinary team. We're able to get, so now at our QA process, we actually have, residents, midwives, other attendings, anesthesia team, the head of anesthesia, head of nursing, risk management. One of the things that we found was really useful was having IT on board, because part of it was a lot of it just when we first started, a lot of things had to be pulled out from Epic, and it was really helpful to have them present to say, hey, this is something we can do, cannot do. So we had a lot of meetings as well behind the scene with IT to get things going. So that was really important, as well as social work. And just from the transition from what we had from a departmental review to now a robust multidisciplinary review, I think that's been a great change. As far as things that made it difficult, part of it having a big team is the buy-in to attrition rate. I think over time, just new roles get assigned, people come, people go. I think one of the aspects that I find is more difficult with having a more robust team is, there's certainly people come and go. And especially during COVID, with that pandemic, we had to even, shut down for a little bit where we didn't get a chance to meet for a little while. So, those are some, successes and challenges that we had.
Thank you, Peter. I think you highlighted an important point. When you're trying to do a project like this, the institutional buy-in is so critical. And it was highlighted at your place in terms of getting your chief medical officer on board, getting all the people that really needed to come together to devote the resources to get this going. And it's no minor challenge. And I think that's a lesson we can share. Linda, your challenges as an abstractor and as a case identifier, how did you find these cases? You had to get all the blood, the women that were transfused 4 or more units of blood, all the ICU admissions. What was your strategy for making sure that you got all the cases that you expected?
Thank you for having me today. The challenges were difficult at times. Initially, I always relied on receiving information through occurrence reporting or through emails or just a short glance at a delivery record. This requires now that I go through every delivery and see if the patient received any blood. I also go through the census on a daily basis as far as looking to make sure that there's anyone within a certain age group and why is she there? The other issue that came up is because sometimes our patients don't stay in the ICU for days on end. They may only be there for 12 hours or 6 hours for observation. It does require that I occasionally go in twice a day just to take a little peek and see who's in the ICU or who's not. One of the other things that we did to make sure that we gathered as many patients and didn't lose any patients is we partner with Blood Bank. And so now they send us a monthly report of blood products that have been administered on the obstetrical unit to make sure that we're not missing any of our patients.
Thank you, Linda. I'm going to move along to another question for the panelists. What we've heard today is a lot about structural racism, social determinants of health, and many contributing factors to an SMM event are present prior to the hospital admission. And hospital QI committees may not have experience with considering these social determinants of health, really at the root of a lot of these events. So how did your committee deal with that issue? How did you get at the social determinants of health? Peter, I'm going to turn to you first.
Well, I think at our hospital, we had to isolate something that we felt like we could tackle in terms of social determinants. So we actually focused more on an actual disease entity that we think we can tackle. So we focused our attention on chronic anemia because we felt that if we had tackled that, it could maybe, if we help load it up front, then we may be able to help, reduce the risk later on. We can't reduce the amount of bleeding that it would have, but if we have a starting H&H of, 10 as opposed to 6, 7, then it helps a lot in terms of what we can achieve. So one of the changes that we have, in addition to just, early implementation of iron supplement, we actually started doing IV transfusion, iron transfusion in triage. We can actually, the provider can say, you know what, this patient comes in for triage, get her CBC drawn, looks like it's low. You know what, if it's something that we discuss and say, if it's something that's beneficial for this patient specifically, we offer them IV iron just so, intolerance, whatever, that it can help boost their H&H so that we can at least upfront maybe reduce the amount of what transfusion that they would need later on.
Thank you. So Linda, what about things like housing and other kinds of social determinants? Did your committee discuss those and look at those critical factors?
We've started looking at that. We find that often that can be a barrier to care. Some of our patients are in the shelter system and they move from borough to borough, which then impacts how they are able to get transportation to visits. The fact that we are now also doing telehealth visits also helps with trying to keep patients in contact with the healthcare system. It's interesting. You have to actually delve in to make sure that you obtain that information. Sometimes that information is not freely given. And sometimes you find that in a nurse's note, or you find that in a correspondence note that the patient had with the scheduling department as to why she was not able to make her appointments. And then the other thing that providers often do is they will attempt to ask the patient, maybe we can find you prenatal care closer to where you're actually living. Some patients accept it. Some patients say, no, I'll make the trek to where you are because I like you.
Thank you. How about you, Wendy? How does your committee deal with the social determinants of health?
Thanks. I would like to echo what both Peter and Linda said. We too went to early recognition of anemia and treatment with both oral supplementation as well as IV iron when necessary. We started incorporating a lot more of our social work notes. I should say that we did have several talks for our entire department on implicit bias, on social determinants of health, et cetera. During the same time, health and hospitals, of which Kings County is one of the health and hospitals in the HH system, was implementation of something called the maternal medical home. And the purpose of the maternal medical home was to provide enhanced wraparound services for individuals who are identified as being increased risk of having an undesired pregnancy outcome. This can be due to medical reasons, behavioral health reasons, social determinants of health factors. And so our maternal medical home coordinator and or social worker really became integral toward planning a pregnancy for patients who may be at increased risk for an adverse pregnancy outcome. They really are kind of one of the go-tos for referrals, both in the hospital system and to our community-based organizations. And we really started feeding back information. So if we found anything from a case review that could have been relevant, either to the social work department and or the maternal medical home, we would integrate that into our discussions and give the information back.
Thank you. We're going to move along to what I think is probably a very important question. And if you could each share what your most important significant change came out of this SMM case review. Linda.
So one of the areas that we identified was sepsis and pregnancy. Our hospital has the majority of the patients enter through the emergency room department, and they are screened for sepsis at that point in time, and a bundle and protocol are utilized. We didn't have that individualized bundle for obstetrical patients. We weren't doing that screening in the triage area. So we've gathered together a group of participants, a group of stakeholders, as far as the labs, as far as IT, infection control, nursing, and we now are trying to get a screening tool and also to implement a bundle and make sure that all of our patients are screened for this and are treated appropriately. You're muted.
Thank you. My turn for this technology. Wendy, could you talk about one of your successes?
Sure. I think one of our successes really came about with the move to earlier use of tranexamic acid or TXA. What we found by this process was a much faster feedback loop to our providers. So when cases were being reviewed, we, like I said, analyze them, and then really our director of quality and obstetrics, Dr. Dana Bryant, I'll give her a shout out here, would reach out to the individual providers and let them know. And that could have been positive feedback or, things to be improved. And we really saw positive reinforcement of desired behaviors, also with departmental emails, congratulating people, shouting them out. And that really helped to make sustained change.
Thank you. How about you, Peter?
Oh, I think the biggest change and success that we got from the process was we were actually implemented a best practice advisory that FHIRS for a postpartum hemorrhage risk assessment for every admission. So when a patient gets admitted to the hospital now, the resident or midwife who's admitting the patient, they get a BPA that FHIRS, and then they have to answer the questions, and we'll strategize, we'll break into their high, moderate, or low risk. Any patient that fits into the high risk category, they automatically get, 2 large bore IV, the PPH meds automatically ordered so that they're in the room or readily available. I think that's kind of subjectively, and again, we don't have specific data to show how it's changed over time, but I think just it makes postpartum hemorrhage that much more at the forefront. just being aware of it, just being paying attention to, hey, what's her risk score? What's her risk assessment? And at least it's a part of the conversation all the time, so I think that helps reduce it post, at the delivery, just so that you're aware, we're already on top of it. So, hey, the patient's already got the IV. Even the residents say, hey, does she have a second IV in already? Yes, she's got it. So I think that's been a big change.
Great. So just in closing, for questions for the panel, I want to know, do you recommend this process to other hospitals? Should they do it? Is it sustainable? Wendy?
I'm going to give a big shout out and say, yes, absolutely. I highly recommend it. Having trained at Montefiore under the auspices of you, Cindy, and Linda, I was used to the QI process. It was a little bit more difficult to start that, especially without the assistance of DOH and having a chart abstractor. Dr. Zoe Thill was our chart abstractor, and she was absolutely wonderful. She became part of the family and really helped move this process along. So I do highly recommend it. It was incredibly useful to enact and sustain change. We appreciate the assistance we got, and our goal is definitely to keep it going.
Great. Peter, Linda, you recommend it? Peter?
Absolutely. So for our hospital, I envision that we will keep this process going forward, just because it's been such a positive change in terms of the whole review process. And also want to give a shout out to our abstractor, Renee Florentino, who had to leave the program because she went to do bigger, better things. And then we have now Anna Thomas, who's been abstracting for us, and she's part of the team. She's involved with MHQIN, and she's during simulations. She's with us during also any grants writing. So, I mean, she's a big part of the team.
Okay. Linda, what do you think?
I definitely think the project needs to continue. I think it highlights the things that you sometimes miss when you only do the medical end of the review. And I think it attunes us to making sure that we begin the process as early as possible to identify issues that go on. I think sometimes in our prior QI process, we were really focused on from admission until discharge. And this process has enabled us to enlighten from prenatal care, from preconception to moving forward. So I highly recommend it.
Thank you. Okay, so now we're going to take questions from the audience. So you can use the Q&A feature on Zoom, and you can also share your thoughts on social media. I think Hannah is going to be working on collating the questions, and then she will read questions from the audience. So if anyone has a question, please type it in, and our panelists will respond as best they can.
Hi, thanks, Cindy, and thank you all. That was really illuminating and great to hear from you. Well, first, there's been a lot of interest already and interest in following up with you panelists directly. So what I'm going to suggest is if my colleague, Abby Cook, who is managing the chat, if she could drop my email in the chat, and I can then put people in contact with our panelists. The first question is, have any of the teams engaged home visitors or community health workers or doulas as members? And if not, if you could talk about that idea and your thoughts on that.
Who would like to take that one on? Wendy?
I knew you were going to choose me.
I know, you've got the medical home, that's why. So do you have community members on your QI committee?
We do not. I think, it's definitely an idea. We've talked about it. I think even though the cases are abstracted, they're not necessarily de-identified. They are when they are entered into the system, but when the committee is discussing them, they may or may not be. That would be something we can and should consider.
Okay. Any other responses? Peter, do you have community members? How do you approximate a community member on your committee?
Right now, I echo what Wendy just said. Within our review, we do have, patient identifiers. So I think right now, I don't envision that we would have an outside member at this time. Certainly, it's we could envision doing that in the future, and I can see that would make our process even better. And right now, currently, we're actually doing all of our, I don't know if the other teams, the other panelists are doing the same thing, but our QA meeting actually now is virtual. Just like our summit now. So that actually have found one of the changes that we've had is that a lot of our feedback is they really like this format because they're able to see everything that's on the screen. They can follow along with the any questions that anybody asks. Hey, what about that? What's her H&H beforehand, or what happened here? What happened here? We're able to look up at the time without having to go digging. However, that does involve sharing a more patient identifier, so that may be something that would have to consider.
Thank you. Here's another question. Could Dr. Wilcox say more about the interventions related to unconscious bias or microaggressions?
We had several grand rounds with both speakers from the Department of Health, also Health and Hospitals, employed a group called Perceptions Institute. That wasn't necessarily for our department, but that was for hospital leadership. And in several discussions on a department level, we've led discussions on implicit bias. There are trainings that are coming that are going to be more widespread. They're e-based learning modules. They're through the hospital system. They're certainly for all new hires, as well as for our re-credentialing process. Our simulation teams in health and hospitals are also working on a simulation that employs some of the concepts on implicit bias in a simulation that everyone will have to take. So some of the parts that we've done so far employ more traditional methods, such as the grand round scenario, but we're also looking forward to having some of the simulation scenarios, which will offer a different type of learning.
Here's another question. What makes the abstraction process so human intensive? How could we adjust systems to make key information easier to find and put together?
Linda, do you want to pick up on that one?
I think if the initial interview is in depth and the problems are identified and placed on a problem list, or however the documentation system in the medical record presents itself, so that those can be highlighted, that would help a lot. Unfortunately, or I shouldn't say unfortunately, but sometimes what happens is the patient doesn't highlight it as a problem because, as far as they're concerned, it's their norm. And it's part of a conversation that may occur with a provider, may occur with a registration clerk, may occur with a scheduler, that then highlights the issue. So I guess it depends on what is deemed to be an issue or something that is going to contribute to care. I don't know that there's a simple way to fix that.
How about, here's a question about buy-in. How did you get buy-in from hematology?
I'll raise my hand.
Peter, oh, you're going to do it, Wendy. Okay, go ahead.
Sorry.
That's
no, Peter,
good.
if you want Peter, go ahead.
Well, Peter did this iron infusion thing, and I would assume that it took some doing with hematology.
Actually, surprisingly, it was just something that happened within our own department as opposed to hematology. Maybe our program directors, or chairman had spoken to them on the side, but it was something that we decided that it's something beneficial, and it actually worked. And now we've been able to do it, offer it in triage. And as far as I know, we haven't had any issues about transfusing in the triage. But that's, well, maybe we'll see later on if there are issues arise, but so far it's been good.
Wendy, how about with the tranexamic acid? Did you have to get hematology involved with your new protocols for that?
No, we didn't. That was more pharmacy, and they were very receptive and added it to our Pyxis machines, both in labor and delivery and in the OR. I echo exactly, we had the same experience that Peter did at his facility in terms of with the IV iron. We just took it on ourselves and we give it in triage. But actually, I was going to answer a different question. I thought when I heard the question, it was how do we get blood bank involved? Because they were a regular part of our review process and committee. And actually, they were very happy to be involved. One of the problems that they had with our department that they wanted to fix was ending the massive transfusion protocol. We would always start it and we kind of got that process going, but people would forget to call them back and turn it off. And so they said that in that way, we sometimes wasted some units of blood, which is a huge no-no. And so they found us as ready and willing partners, and they were quite interested in joining the committee, and they would always remind us whether or not the protocol was turned off or not. And I have to say that through their involvement, we improved. And yes, we are now calling the blood bank to say it's finished. Thank you.
Terrific.
I had something to add to what Linda had actually, because I was curious what the other panelists thought in terms of what she said about just pulling these numbers, because that was one of the identifying these patients was a difficult task. And that's something that at Jamaica, we took a long time, and now we've actually fine-tuned it where Epic will send us a daily notification with any ICU admissions and any transfusion greater than 4 units, and we get it in the daily report. And I'm wondering if that, at the 13 other, institutions that we have in the MHQI network, is that something that they have, at least something that they felt that, maybe collaboration could help. One, our IT department could say, hey, this is what they use to pull their numbers and their data. You want to share that? And so that you don't have to start from the ground up with every single hospital that's involved.
Thank you.
Thank you,
I think
Peter.
this might be our last question, given the time. But have your findings led to changes in the delivery of clinical care?
Let's go down the list here. Wendy.
Absolutely. We're finding a much faster response to hemorrhage. We're finding much more adherence, both to the bundle, the hemorrhage bundle, and the massive transfusion protocol, as well as the blood bank policy of calling off the MTP. So yes, I would say absolutely. Thanks.
Peter, at your place?
Definitely. I think now, like I said about the BPA with the PPH, I think our team is much more aware, and the going from the residents, nurses, midwives, everybody's more aware that PPH is an issue. And I find that subjectively, there's been a lot less PPH, a lot less need for MTP within our institution. So I would say I can contribute to that to this SMM process.
So just for everybody, PPH is postpartum hemorrhage, MPP is massive transfusion protocol. We have lay members here, so we need to be clear. Linda, last word for this question. Has it led to clinical change in your place?
I think it has. I think one of the things that happened is there a greater collaboration between critical care and OB, and between obstetric and gynecology, as far as calling for assistance and recognizing earlier on that you may want another expert opinion. So I think that does help us quite a bit.
Well, thank you, everyone. I really would like to thank the three panelists for sharing all their thoughts, their participation, and this was really a team effort to get this up and running. So again, thank you to the panelists, thank you to all the folks at the hospitals, our abstractors, and of course our operations team at DOHMH. And I'm going to hand it now over to Hannah. Thank you.
Great. Thank you, Cindy, and thank you, panelists. It's really been a pleasure to work with all of you on this project, and it was really, really very informative. Thank you. So now we are at 1:30, and we're going to take a break. We'll return in 15 minutes at 1:45. We encourage you to stretch, check in with yourself and your family and your pets. And again, remember there's this Q&A function to ask questions in the next panel, and use the chat function to chat with one another and get each other's emails and so on. And don't forget to, if you are a social media user, to join the Twitter storm and tweet to hashtag NYC Health Summit. Thank you so much. We'll see you at 1:45. Okay, I think we'll go ahead and get started again. Welcome back. I would like to ask the next panelists to come up, lead of the panels to come up. Ms. Falake Iniola, I see you. So thank you. So welcome back. We hope you had a nice break. We are now going to turn to the second panel of the day, where we're going to hear about and from women who had mothers who had a severe maternal morbidity, and the people who interviewed them. So the leader of this panel today is Ms. Falake Iniola. She is the principal investigator of the qualitative study that we implemented under this project of women's experiences with severe maternal morbidity. She was the lead researcher in overseeing the research process. She is also the senior evaluator of the Maternity Hospital Quality Improvement Network, which is a multi-component initiative aimed at reducing severe maternal morbidity and mortality in 14 New York City hospitals. Ms. Iniola is an applied public health researcher and received her master's in epidemiology from Columbia University, where she also is also completing a doctorate. She received a BA in community health and sociology from Tufts University. Prior to joining the Bureau of Maternal, Infant, and Reproductive Health, Ms. Iniola held several research and evaluation positions within the health department, including at the Center for Health Equity and the Bureau of Maternal HIV and AIDS. She will now take us through the second panel.
Thank you so much for that introduction, Hannah. Good afternoon, everyone, and welcome to the second panel of a Maternal Health Summit. I'm thrilled to be moderating today's panel, where we have participants and interviewers from a small-scale study exploring the firsthand account of women who faced a life-threatening complication during childbirth. We will also be speaking with two clinical and academic research experts who will share experiences from their work to address maternal health inequities. We're all very much aware of the unacceptable maternal health disparities that exist for women of color nationally and here in New York City. Indeed, that is why we're all here today. And here at the Health Department, we acknowledge the role that systemic and interpersonal racism, as well as structural inequities, play in worsening health outcomes for Black and Brown women in New York City. We're responding to this urgent need by partnering with institutions, researchers, and community members to develop and implement needed strategies. And before I start, I would like to thank our research team, specifically our research consultants, Dr. Christine Martin, Dr. Adina Knack, Dr. Mimi Niles, the entire DOH Severe Maternal Morbidity team, and most importantly, the courageous women that lent their voices to this project. Today, I'll start off this panel by describing our study, which is one component of a larger DOH-MH effort to address racial inequities in maternal health by centering the voices of impacted individuals in quality improvement strategies. The purpose of this qualitative study was to explore the perceptions and experiences of women who faced a life-threatening complication during childbirth. Our research questions centered around how women experienced pregnancy, childbirth, and the SMM event. What were women's perceptions of medical care during pregnancy and childbirth? For example, the quality of care received, communication with providers, and respectfulness of care, as well as their experiences related to implicit bias or racism, whether interpersonal, institutional, or societal. We also wanted to explore the emotional, physical, social, and financial consequences of the SMM event on the women and their families. And finally, we explored how the women experienced the process of recovery and healing from the SMM event. We conducted 15 in-depth interviews with a diverse group of women recruited from participating hospitals and the surrounding communities. Data were analyzed based on the principles of grounded theory and using comparative methods to adjust analytic categories to theoretical concepts. Our overarching coding categories looked at different stages in the SMM experience: the prenatal period, childbirth, the spiral into acute SMM, the recovery from SMM, and adaptations to other postpartum challenges. We then re-examined the data with a focus on the medical, social, and psychological aspects of the participants' SMM relevant experiences and their experiences with significant others, the healthcare system, clinicians, and employers, among others. We developed an interview guide in consultation with our maternal research experts, Doctors Christine Morton and Adina Nack. The semi-structured interview guide centered on general pre-pregnancy health, reproductive history, pregnancy health and prenatal care, childbirth experience, which includes labor, birth, and postpartum medical and mental health treatment and recovery, concerns and reflections, and advice for other women who may face these complications, as well as the clinicians caring for them. So let's take a look at the women in our study. Of the 15 women interviewed, majority self-identified as either Black non-Hispanic or Hispanic Latina. A third of the women were Spanish speakers of bilingual English and Spanish, and 3 of the interviews were conducted in Spanish. Almost 3/4 of the women were employed prior to birth, and 8 of them were healthcare workers. And almost half of our sample were women who were unstably housed or had to move their residence during the pregnancy or postpartum period. We also collected data on the reproductive health characteristics of the women. 2/3 of the women in our sample had a cesarean birth. 6 of these were primary cesareans and 4 were repeat cesareans. The primary SMM diagnosis among the women included hemorrhage, which is the loss of a large amount of blood in a short period of time, either internally or externally. And over half of the SMM births ended up in the intensive care unit soon after birth. Looking at the findings from the study, the key domains that emerged around women's experiences focused on patient-provider interactions, communication with providers, the healthcare system, and the postpartum recovery after the SMM. We'll now take these domains one at a time. The first domain around patient-provider interactions had to do with the style with which providers interacted with women and their families, and how that influenced women's experiences of the SMM event and their recovery from the SMM. We identified 3 interaction styles: the biomedical, moral surveillance, and patient-centered models. The biomedical model of care involved interactions that are characterized by the clinician's treatment of the patient's body in a scientific or neutral way. In this model, women are often viewed and treated as patients, cases, or diseases, and interactions are short and clinically focused, typically with the use of technical jargon. With this style, clinicians may report health information to patients and prescribe a plan of action without input from the patient. The next style is the moral surveillance model, and this model, which was coined by one of the researchers within our study, Dr. Adina Nack, is an interaction style in which clinicians use information collected about patients to scrutinize and judge women's decisions during pregnancy. In this model, explicit or implicit biases may come through during medical encounters where clinicians may communicate negative judgments about patients' characters. For example, their morality, their intelligence, or responsibility. And this often leaves patients feeling judged, discredited, or discounted by the clinician's words or actions. The last style is the patient-centered care model. The Institute of Medicine defines this as providing care that is respectful of and responsive to individual patient preferences, their needs and values, and ensures that patients' values guide all clinical decisions. This model considers the patient as a whole person, considering the physical, social, and psychological ramifications of the health event on the patient. This is care that is ideally grounded in principles of respectful care. We're now going to look at some of the ways in which these models played out using the women's own accounts. One of the ways in which the biomedical model manifested was through paternalistic behaviors on the provider side. A study participant, a Hispanic woman who experienced the placental abruption and hemorrhage, said of her physician. He said, "Okay, so we have a placenta abruption patient. We're going to perform a C-section on her. They started saying scientific words, doctor words that I didn't understand. The whole time I was listening to them, but I didn't understand. But I'm praying like, God, please help me, help my child, make sure everything is fine." This exemplifies the way in which the patient was not engaged in her own care when providers followed this approach. In the second model around moral surveillance, women reported experiencing judgment and downright disrespectful care, either because of who they are or some information that had been collected about them. A third of our participants reported experiencing this type of care. One of them, a Black Hispanic woman who experienced a postpartum hemorrhage, said of the nurse that was caring for her, "She didn't even introduce herself. She was just like, just lay on the bed." That was actually the same nurse that when I grabbed her arm to hold when they were going to put the IV in my arm, she was rude. She was very nasty to me. So here we see a situation where a woman undergoing a life-threatening complications feels disrespected and disregarded by the care provided to her. Women also reported not being listened to or having their personal accounts of their medical experience disregarded by providers under the moral surveillance model. For example, another Black Hispanic woman who experienced a postpartum hemorrhage said, "I had to ask for OxyContin. The nurses were very hesitant to give it to me because I had a vaginal birth. I'm trying to explain to them I didn't have a regular vaginal birth. I had traumatic birth. I'm not drug seeking. I just want to be comfortable enough to care for my child." This shows a situation where a woman in extreme pain from a severe event is dismissed and not provided optimal management for her pain. And finally, the third model of care was the patient-centered model. In contrast to the feelings of disrespect, disregard, and disconnection that was associated with the moral surveillance and biomedical models, the women in our study described interactions with patient-centered clinicians that were respectful and left them feeling cared for as a whole person. For example, a Black Hispanic woman recounted how she felt while a nurse was caring for her. She said, "It was one nurse that she was really nice to me. She knew that I was uncomfortable with getting a catheter in. She knew I was afraid of needles. She went as far as getting some numbing cream so I wouldn't feel the needle. She made me feel comfortable." The patient-centered model also left women feeling seen and heard, even while battling a life-threatening situation. Here is a Hispanic woman who had an abruption and hemorrhage, recounting the nurse's personal attention to her. "Every time she comes close to me, she sees me crying and she tells me, 'You're going to be okay. Everything's going to be okay.' She couldn't believe that she was finding that I did not die. I was in the ICU and she came all the way from her home on her day off to come see me." We see from these two accounts that it was important to not just focus on the medical aspect of the care, but also pay attention and respond to the physical and psychological ramifications of the SMM event. This type of care is grounded in principles of respectful care, such as those outlined in the New York City Standards for Respectful Care at Birth, which was introduced earlier today, and which the health department is currently implementing in maternity hospitals across New York City. The second domain that emerged around women's experiences involved communication between providers and the patient. Women discussed the lack of communication with them or their support people. More importantly, they discussed the lack of clear communication about the medical issue. They described not receiving communication that allowed them to know what happened to them and not being engaged in their own care. For example, a Black Hispanic woman who had experienced a postpartum hemorrhage recounted how she felt while the doctor was communicating with her. She said, "Basically, the provider just told me I lost a lot of blood. He didn't even go into detail of what was going on. He just told me that my uterus had stopped pumping, so he had to reopen me. No, it did not make sense to me." We see from this example that in a life-threatening situation, women want to know more and want to be engaged in a way that is clear and sensitive to their unique situations. The third domain that emerged around women's experiences focused on the healthcare system, navigating the system during the prenatal, birth, and postpartum period, especially if facing complications and after experiencing a severe event. Women reported having to navigate multiple uncoordinated care systems, at times receiving care from different providers. This specific quote, however, exemplified a positive experience that a Black Hispanic woman with preeclampsia had with her GYN. who was different from the providers that saw her during the birth hospitalization. She said, "I like the fact that I didn't waste a lot of time at the appointment. She would see me when I arrived. I like that she was very direct with me. She treated me in a friendly way. I felt very comfortable. It didn't feel like a burden." And the final domain that emerged around women's experiences with an SMM involved the postpartum recovery after the SMM. We identify 3 key areas within the recovery period: the physical recovery from the severe event, the emotional recovery from going through the severe event, and the added challenges to recovery and care posed by other social determinants of health. For the first area around physical recovery, we saw that women who survive an SMM described needing additional medical and social support during their postpartum recoveries. One participant, a Black woman who had a pulmonary embolism, said of her recovery, "I have to take medication every night. When I came home, I had to take 2 different blood thinners. I have to do the one with the syringe, poke myself with it morning, evening, and I have to take the medication at the same time. It wasn't easy. I wish I'm over it." We see that there is an express need for health professionals with specific expertise in helping women recover and manage unexpected pain, disability, and dysfunction while trying to care for their newborns. The second area of recovery was around the mental health needs that follow the SMM event and the emotional recovery that is necessary for some women after undergoing the event. Here is an account of a Hispanic woman who had a postpartum hemorrhage after she returned home. "One night, I called my mom around 11:30 p.m., just crying and feeling totally helpless because I was having a nervous breakdown. I couldn't figure out how to handle the situation. I couldn't recover because I had to take care of her child. I didn't have anyone to help me." And the last area within the postpartum recovery was around the added challenges that women face, especially for women with intersecting vulnerabilities such as underlying health conditions, unstable housing, financial strains, and limited social supports. In addition to the physical and emotional toll that an SMM takes on a woman in the immediate postpartum period, these added social and medical needs further complicate recovery and could further destabilize the mother. Here we have an account of a Black non-Hispanic woman who experienced the postpartum hemorrhage, talking about how this all took a toll on her recovery. "I still have pain. I still have cramping where it feels like I'm getting my period. It's very uncomfortable. I was supposed to get an ultrasound. I haven't been able to go. I have 4 children and I homeschool and I work. It's very hard to get out for me." So we see here that dealing with other socioeconomic challenges with little to no support further inhibits needed postpartum care and recovery from an SMM event. In summary, the 4 domains emerging from our study highlighted both positive and negative experiences. In particular, experiences of not being listened to or believed by health providers led to feelings of disrespect. Negative experiences created fear, stress, trauma, and frustration. Negative experiences also led women to mistrust their healthcare providers and the health system at large. Experiences of care further influenced women's decisions about whether to seek care and when to seek future needed care. Women also experienced unique physical and mental health needs due to the SMM event in the postpartum period. Here is an example of a mother whose experiences during the severe maternal complications led to her distrust of the healthcare system. She's a Black non-Hispanic woman with a postpartum hemorrhage, and she said, "I didn't go back there for my 6-week checkup. I was supposed to get a tubal ligation. I have not set foot back there. This whole incident, it's made me even more hesitant now with healthcare. I will figure out some way not to get pregnant because I'm not getting pregnant again. I still have pain. I'm still uncomfortable." We see in this account the impact a negative experience can have on a new mother's timely access to needed health services, which may lead to gaps in care. And finally, severe maternal events tend to be traumatic, not just to the mother experiencing the event, but also to others around the mother, often because of what they may have witnessed and experienced during the event. This quote by a mother who had a particularly severe event really exemplifies the trauma that follows. I was happy to have the baby finally with me in the house, but 2 weeks passed and I was feeling depressed because I would think about everything I went through those 2 months in the hospital. My husband is traumatized at things that he's seen with his eyes that I couldn't see because either I was too drugged up or asleep that whole time in the ICU, and I wasn't aware of a lot of things going on. It gets better, but I still think about it like, damn, this really happened to me. I'm still traumatized. So as we move into our panel discussion today, we can see that these powerful and private accounts really pull back the curtain to reveal what it means for a woman to go through a near-miss life-threatening pregnancy complication, especially in the context of her interactions with the healthcare system. These experiences further underscore the opportunities that exist for addressing these severe events and preventing re-traumatization of impacted people. For more information and to hear more of these women's stories, you can refer to our SMM Project Toolkit. It is published online, and the link will be shared with all attendees here today via the chat and at the close of the event. So now I will turn to our esteemed panel to discuss some of the findings and strategies for moving forward. I will now ask each of the panelists to turn on their videos as I introduce them. Our first panelist today is Aya Abdul-Adeen. Aya, you can turn on your video. Aya is one of our study participants. She's a mother of a 1-year-old daughter and a doctor. Aya is originally from Iraq and came to the United States 5 years ago to pursue a career in medicine with an internal medicine specialty. Currently, Dr. Abdul-Adeen works as a second-year resident doctor in the internal medicine program at Montefiore Medical Center, and also has been working as a frontline healthcare worker in the COVID-19 pandemic. We also had another study participant, Ms. Taylor Monique Pinnock, who was going to join us today, but unfortunately she was unable to join us at this time. We would like to thank her for participating in our study and lending her voice to helping us understand and address factors impacting maternal health in New York City. We also have on the panel today, Ms. Nicole Jean-Baptiste. Ms. Jean-Baptiste is one of our study interviewers, and she's a mother of 2, a full spectrum community-based doula, lactation counselor, yoga instructor, and oral historian. Of Southern American and Caribbean ancestry and based in the Bronx, New York, she strives to center the borough and the Black experience in the birth and social justice activism in which she engages. Nicole recently served as a community doula consultant for the New York City Health Department's COVID-19 Perinatal Task Force. She is the founder of SESA Doula Services and co-founder of the Bronx Rebirth and Progress Collective. Also with us today is Ms. Oriana Sanchez. Oriana is a public health provider, public health professional, and also one of our interviewers, working to lower local infant mortality rates with Public Health Solutions Queen's Healthy Start program. Her previous experience includes working with immigrant communities in New York and in family detention at the southern border. She's currently pursuing a master's in public health at the SUNY Downstate Health Sciences University and holds a BA in political science from CUNY Baruch College. We're also excited to have 2 of our collaborating researchers with us on this panel. First, we have Lane Friedman. Dr. Lane Friedman is Professor of Population and Family Health at Columbia University Millman School of Public Health. She directs the Millman School's Averting Maternal Death and Disability Program, a global program of research, policy analysis, and technical support that since 1999 has worked with UN agencies, NGOs, and governments in more than 50 countries in Asia, Africa, and the Americas, all to reduce maternal mortality and severe morbidity using a human rights-based approach. And last but definitely not least, we have Dr. Mimi Niles. Mimi Niles is a full-scope midwife and a midwifery care researcher based in New York City. Her work explores the potential of integrated models of midwifery care in creating health equity in historically disenfranchised communities with complex care needs. Dr. Niles serves on the board of directors of the National Association of Certified Professional Midwives and is currently a postdoctoral research fellow at the Birthplace Lab at the University of British Columbia. And she continues to practice midwifery at Woodhull Medical Center here in Brooklyn, New York. Welcome to all my panelists, and thank you all for joining us today to share your stories and to engage in this important conversation. I will now start this afternoon's conversation with Dr. Aya Abdul-Adim.
Thank you, Ms. Eniola.
Great. So, okay. Aya, in our study, some women reported that they did not feel like they were being listened to or believed by health providers. Reflecting on your own experiences, why do you think it is important for women to be listened to, especially when it concerns issues around their body, their children, or their care?
Yeah, hi everyone. Thank you so much for having me today. And so, yeah, this is a very good question, actually. I believe that the patient have to be at the center of their own care. Although the medical professional and the providers have the medical point of view, but still I believe that the patient should be engaged in their own care. Having said that, some people believe that no, that does not really apply because, you know, people have different level of education. Maybe they don't really understand what is the right thing for them to do. I totally understand that. And I apply that to my daily life when I take care of patients. I explain to them in simple words, this is your option. This is what is going to happen. What do you think? Do you want us to do this? Do you want us to do that? I think this is a major part of the patient care. It also helps the patient to trust their providers as well. So it's one of the major things that providers should do. They should engage their patient in their care. I know that it is, you know, everyone have their different practice, but I would really appreciate if providers would do that with most of their patients.
Great, thanks so much for that response. I like that you said giving patients options is important, and it also helps build trust with the providers. Given the important role that trust in the provider system has on seeking timely and appropriate care when dealing with an SMM, how do you think we as a medical and public health community can begin to address this issue?
Yeah, so trust is a major thing in patient care. So when I trust my provider that she or he will address my concern, I would never hesitate to go for it. But if I don't, then I will think twice before going to my doctor and asking for medical attention for two reasons. First, because if I know they're not gonna listen to me anyway, and I'm not gonna get the right response, why would I waste my time? Why would I go? Why would I even think of it? And second, because sometimes when you trust your provider, you think of them as the first line. They're just like your professional family who will give you the right answers. So if you don't have that rapport and if you don't have that trust, that might have lead to complication. In which way, I have a concern, I'm not going to ask for it. I'm not gonna go today because I'm doubting the response that I will get. So that will delay my care, and it might lead to indirectly to some complications because I didn't go in a timely manner. So many health issues is very time sensitive, especially when it comes to maternal care and delivery. So if I don't go in the right time, I might not get the right treatment or that at the appropriate time. And that might be caused because I don't really trust my provider.
Mm-hmm. Yeah. So that's very important. The timeliness of the care, especially when facing something like a complication, is key. And in our study, we actually found that the type of care that women received influenced their decisions about whether and when to seek future and needed care. And I know you're a medical provider yourself. So as a medical provider, what recommendations do you have for your colleagues, other medical providers, to ensure that women experiencing a life-threatening complication are centered and involved in their own care?
Yeah, I think and I really believe that the major thing is to involve the patient in their own care, which means like patient have these options, option A and option B. Explain, why are we going through this? Are you very consistent with going through option A, not option B? Why not? Maybe something happened, the plan has changed because, during delivery, for example, things change and sometimes it's unexpected. So just engage again with your patient. Do you still want to do this? Do you want to pursue another option? Why? Because this happened, because that happened. What do you think? Are you still consistent with your first opinion? Maybe we discussed something during our prenatal care that does not apply now. Can we discuss it again? I know it's very frustrating. And at the time, specifically like in my situation, it was very frustrating. And maybe the provider thought it's not the right time to have the discussion. But from my point of view, it was the perfect time to have that discussion. Because at some point, I reached to a point where I was told, okay, we are going to an emergency situation. I had no other option. Okay, yes, sure. Do you want me to say no? Of course, I'm not going to say no. You just gave me an emergency option that I have. Either you take that option or you die. Of course, I'm going to go. So you're not really giving me options rather than just doing it. That's it. Whether if they engaged me earlier in the discussion, maybe I have gone to my option B rather than being consistent with option A that might have led to all my complications.
Yeah, that's very important. So you believe having providers engage with their patients early on in the pregnancy and giving them the appropriate options would allow them to, make
Definitely. Yeah, maybe even during the prenatal care, when you go to their visits, maybe you have to have full discussion about all your options and the possible complications. Some providers might think, oh, I don't want to scare my patient. You're not actually scaring your patient. You're just mentally and physically preparing them because things happen. So in case it happened and the patient did not have an idea about it, it will be even worse. So engage with them earlier. Tell them these are your options. I know you might lean towards one option rather than the other, but things can happen unexpectedly and we might have to go into the other option. What do you think? So that will, have this discussion even in the prenatal care where you're still relaxed, still, in your full mentation, not really in so much distress. So you might have a good, awareness of what's going to happen.
Yeah, that's very good advice. And finally, from this study, we found that the way that clinicians interact with women and their families can profoundly impact not just their experiences of the SMM, as you've mentioned, but also their recovery from the SMM, specifically their emotional recovery. Reflecting on your own experiences, what are some ways in which medical providers and professionals can address the emotional toll that an SMM takes on a mother, especially in the postpartum period?
Yeah, definitely. Oh my God, this is a major part of the recovery. So when you ask women generally, how was your delivery? Someone who had a straightforward, normal delivery with no complications, she will tell you, oh my God, it was a very horrible time. Just imagine how would it be if it happened with all the complication and it was unexpected completely. It's very, very traumatizing, exhausting, not only to the patient and to the family as well. And also, that maybe the provider have had that incident so many times. So to them, it's okay. It's one of these incidents, but to the patient, it's their first and it's their worst. So it is when you acknowledge that, it might help a little bit, but when you tell your patient, oh, these things happened and it happened because of bad luck. This is literally what I hear. That was traumatizing, like seriously. And so they will think, oh, it's okay, with time you will forget about it and you'll live your life normally. Believe me, till this day, I feel like it happened yesterday. Every time I remember all the details, everything. Although at that time I didn't know what happened, but then after I recovered, I knew what happened. I still remember that like it was yesterday. My daughter's birthday was a few weeks ago, and it was like, oh my God, really? It felt like yesterday. It's very traumatizing to everyone, families, to us, and and it takes longer time than expected for recovery. So providers should acknowledge that.
Mhm.
When provider tell the patient, oh, these things happen, that doesn't make it look good. It make it feels worse. You should appreciate that it happened to me. This is the first time it happens to me. I'm feeling bad. So acknowledging that, and it should be in a better way.
Yeah, thank you so much for sharing your story, and we'll get further into the discussion about some strategies that we can use to address recovery in the postpartum period. So now
Thank you.
Thank you. Now I'm going to turn to Nicole. Nicole, we know that historically in the US, Black women and women of color have had worse maternal and child health outcomes. Given this, what role do you see women's accounts of their experiences playing in transforming public and private health systems?
Thanks for that question, and hello everyone. Aya, thank you so much for your very honest responses to the questions that Falake posed, and it's also really good to see you. I actually had the privilege of interviewing Aya, and hearing some of the responses has reminded me of the enormous potential here in having providers truly, hone in on and listen to some of these accounts. I think there's potential to catapult change initially at an individual clinician level. And, hopefully, ultimately, what that will do is allow us to see some true change at a systems level, as well as an administrator level. And this type of support from individual clinicians, I think too often is discounted. It means so much for that small interaction with a nurse or your OB, both during your prenatal visits and during labor and delivery, to be like warm, and personalized. And this person is saying your name, and they are referring to you and your situation as the individual situation that it is, rather than, blanketing it as something that is just thrown into the category of all pregnancies, and this being the norm and this being very common. So ideally, nurses and doctors will have read or listened to these accounts, and rather than deny responsibility for many of these harmful situations, they'll reevaluate each and every interaction with their patients, from the most basic, both prenatally and during labor and birth, to the potentially more invasive, like some of the stories that we were listening to during our interviews. I can't underscore enough that what is said, how it is said, the assumptions that are made, and the histories, both known and unknown, of providers' patients, they matter deeply. In some of our conversations, we've talked about hospital systems being staples in the community, whether or not they're causing harm, which unfortunately we know they are. But that being said, it's really important to know your community, to learn your community. With our communities, especially in New York City, come so many varied histories, and to know histories and cultures and customs. And in my view, it is the responsibility of folks who are the providers of healthcare to learn these things, and I believe that it goes a long way, and that by listening to these accounts, there is potential here for, to be that motivation. And I'd argue that it would be revolutionary, even if what came of this, of providers listening to these accounts, was that each of them now view themselves as insider agents of a sort, integral to the process of this birth justice movement that is underway.
Yes, thank you so much for those remarks, Nicole. I especially like that you said the way things are said and how they're said could potentially cause more harm to mothers, and providers need to take those into account and also understand the community and the people that they're caring for. Another thing that emerged from our study was that several women said that this interview was the first time that they had ever told their full story, their full SMM story to another person. As an oral historian, can you shed some light on how telling a personal story of this account, of this event, can be healing to the storyteller?
Sure. Yeah, I think it's important to acknowledge that, historically in many cultures, oral tradition literally is a healing art. Mm. For example, the tradition of midwifery had been passed down within African and indigenous cultures the world over through the use of oral tradition. We didn't have textbooks. There were not, formalized courses and training pathways to do this sort of work. And we know that midwifery is care work. It's healing work. And so you have that connection between oral tradition and midwifery and this healing practice. So it makes sense that the same practice is the thing that's so critical to what really is the beginning of a reckoning process where the root causes of this particular disparity are concerned. In my training as an oral historian, what I learned was that, oral history teaches us that we experience life while also carrying with us our own individual histories and, our family's histories. And so while experiencing the present for that reason, having our histories with us, some of these more or less explicitly biased, less openly racist interactions that we have, they sometimes hit just as hard as those that are blatantly racist and explicitly biased, because what we're doing is, whether it's conscious or not, we are carrying with us sometimes generations, sometimes ages of histories that carry on, and so to speak about and process these experiences, it has the potential to serve as a form of trauma release. To share one's story, although, after the harm has been done, after having sometimes been made to feel invisible, it's a way for the narrator to demand that they be seen. Like, I'm going to take this time and I'm going to recount step by step what happened and how I felt during what happened to me, while it was happening. And we heard from Aya, like, it's a year later and she remembers like it was yesterday what she experienced, right? So I think it's a reclamation in the sense that specifically in hospital settings, during critical situations, the feelings of the patient often take a back seat to the emergency response, and I can't underscore enough how important it is for us to handle these stories with care. And I think that, one thing I'm really pleased about is that with this study, I feel like to a very high degree that was done. We discussed at length some of the ways that we would support folks if need be, if there were any emotional or mental health support that was needed, and those things were provided.
Yes, thank you so much for that powerful response, Nicole. And I really appreciate your involvement and how much of yourself you poured into making sure that we were able to elevate these women's voices in a way that was respectful and allowed them to be seen and heard, like you said. So thank you for that.
Thank you.
And now I'll move to Oriana, our second interviewer. Oriana, we found that in our study, clear communication from the provider was a major theme. As an interviewer, what advice can you give medical personnel interfacing with patients, around communicating with them to promote shared decision making.
Can you hear me?
Yeah.
Okay, hi, thank you, Falake. So maybe no surprise here that as an interviewer, I think the main tool that can be used to improve communication would actually be asking questions and answering questions in a way that both doctor and patient are walking away with a better understanding of each other's rationale. So I think a little bit echoing here what Aya had said too. To that point, I think the first thing that I would recommend is to consider what self-advocacy can look like in a medical setting. In my day-to-day job, I work with women who are pregnant, and sometimes I have run prenatal support groups. One of the things that we say to them that they can use is to use their brain, where brain actually stands for, and I didn't make this up, asking their doctors about what are the benefits, what are the risks, what are the alternatives of something that may be offered to them. And then to check in with themselves about their own intuition and to either do nothing, meaning they agree with what the doctor is recommending, or to ask for more time, need more time. Now, I doubt that people are going to their doctor and following that to the T, but the idea is to get them comfortable asking their doctors questions. And what we wouldn't then want is for those questions to be met with either disregard or defensiveness, which I think are the two responses that generally, not always, those kinds of questions are met with. So either they get the that's normal, or when they push back and maybe say, it's not normal for me, or can you explain why it's happening? Sometimes there is defensiveness there around maybe even making mom feel arrogant for asking questions about their care. And this isn't to say that patients are perfect people or anything. I'm sure they have their moments, but that generally there's room for these two parties to be learning from each other. And I think that asking questions, sharing the rationale is what hopefully can lead to shared decision-making.
Yeah, thank you so much for that, Oriana. Thanks for sharing your expertise and your day-to-day, and also the lessons that you learned from interviewing the women in this study. I know I definitely am writing down that acronym for BRAIN, and I will likely be, it'll be in my mind as I interact with my healthcare professional as well.
Me too, I use it too.
You shared that, you had to meet women where they are in terms of education and knowledge, without understating what they know themselves. Given those lessons, what are some ways that you think providers can work to gain trust of patients?
Yes, so in addition to meeting the patient where they are, in my experience, especially doing these interviews, I think being respectful of their boundaries, what they're willing and not willing to share. And for me, I know that it was avoiding any personal bias that I may have had that would have led me to underestimate why they were making certain decisions. And for sure, all of these things are connected. In terms of my experience around meeting people where they are, sometimes that was very literal for this project, and we spoke about this, whether it was going to Long Island to meet people, or meeting them at the library if they didn't feel comfortable with me going to their home. As you said earlier on, some of the moms were in an unstable housing situation. But I think figuratively and connecting to, respecting their boundaries, it was being an attentive listener, knowing when not to push or to give pushing a break. Coming back to the point later on, I think, after talking to them a little bit more and gaining their trust. But on that last point, I think in terms of not underestimating people, I think the main thing is they know their lives better than I know their lives. And so I remember this one mom in particular that comes to mind was the mom who was undocumented and who was going from New York City to Boston to get prenatal care, because she had lived in Boston before, and that's where she had had medical care in the past. And here she was from Brooklyn going all the way to Boston to get prenatal care because she hadn't figured out how to do that here. And so initially I found that, yes, a little bit shocking, maybe even frustrating on her behalf. But thankfully, I think, because I have a background in working with people who are undocumented, and I can relate to that fear of not being found out or not getting into too much trouble, not making too much trouble, I understood why it made sense to her. And so I think it goes back to that, knowing more versus knowing better than someone. Obviously, the doctor is going to know more than I am about, my medical care in certain regards. But if I'm not making certain changes or I'm not taking certain steps, well, I know why I'm not able to do that. And so I guess it just goes back to, again, asking questions, trying to relate to the patient, because there can be so many reasons why people are choosing to do things the way that they're doing them versus the way that we wish that they would.
Right, absolutely. And I think, as you said, understanding.
You're muted.
Oh, am I muted? Okay, can you hear me? Yes, okay, so understanding the reasons why women do what they do without bringing our own biases into, can you all hear me?
Yes, we can hear you.
Okay. Without bringing our own biases into that interaction, I think that's one thing that I took away from your remarks. And I think that's very important. It also helps providers see the patient as a whole person, understanding that they have lives outside of the medical event that brought them to the hospital, and some of those lives, those things could be affecting their decisions. So thanks for those remarks, Oriana, and I also thank you also for bringing your wealth of experience into the interviews, and really, like you said, meeting patients, meeting the women where they were. Literally, you went as far as Long Island to see one of our women. So thank you. Now I'll move on to Lynn. Hi, Lynn. So in your study, which interviewed women also, not women with an SMM, but women's experiences at birth, as well as their providers, you found that some women were hesitant to report experiences of disrespect and abuse. Why do you think that is? And how can we as researchers ensure we can capture these things?
Thank you, Falake. We certainly did find that women were hesitant at the time these things happen to report it, as well as perhaps hesitant in the research process. So, for many of the women, I think some of the things Oriana just said give us a sense of why they might not report. I mean, people who are undocumented, people who are uncomfortable, and also what Nicole was saying about all the sort of stories that people carry with them, the histories they carry with them. If we just ask them a straight, yes, no question, and think we'll get an answer that describes their experience, I mean, that's, I don't think that's what we can expect, and we shouldn't take a first answer to a simple question as some kind of absolute truth. We know that from our research. So I think both Nicole and Oriana, as well as Aya, have given us a sense of what the kind of patience and listening that it takes to understand what's happening.
Thank you for that. Also, in your study, you had an opportunity to interview the providers, and you actually found that some providers reported seeing instances of care that was, not respectful. How can we use these findings to drive change in maternity care settings?
Yeah, thanks. Well, we did have the opportunity to interview nearly 100 both clinical providers, but other people who worked in the hospital system about disrespectful care. And indeed, they widely reported seeing exactly the same things in their work settings that women were reporting. So they know it's happening. But I think what's really important is that we not just see this as individual actions. People are not working in a vacuum. And so our starting point is actually that health facilities and health systems are themselves social institutions embedded in societies. They're not separate from the society. So all the dynamics that happen in the wider community happen in this health setting too. So, things like structural racism, power dynamics, professional hierarchies, the effects of history of a segregated health system historically, of issues between public and private, all of these things are core to understanding why the system itself doesn't always support providers to do or to treat women even the way that they would say women should be treated. And so I think what's really important is that we think of it as a systemic problem as well as an individual behavioral problem. And the upshot of that is that, and I say this as a lawyer, really, just making a new rule is not going to change this. As important as the standards of care are, just announcing new standards won't change this. I think it really takes both that and attention to the health system itself as a complex system.
Yes, thank you for that, Lynn. And I like that you said that these hospitals are not standalone. They embody the underlying social structures in society. And to address, change, it has to be on both the individual provider level, but also the systemic level as well. So thank you for that. Now I'm going to move on to Mimi Niles. Hi, Mimi. So in our study, we found, as we've discussed earlier, that trust in the provider's advice can be impacted by a negative experience. As a clinician yourself, what are some of the lessons we can learn from this qualitative study to drive change and ensure that women, especially Black women and women of color, are receiving the care that they need?
Well, thank you, Falake. And I would be remiss if I just didn't honor the fact that I was able to read all of these interviews and engage with them and really hold a place of honor for the stories that I was being able to witness and being able to engage with. And so I'm really grateful for that in and of itself. I think what I'm hearing from all of the panelists, the word I keep hearing over and over is trust. And that is what your question is about. I think ultimately we have to start to reframe how we think about trust. And instead of thinking about it as, why don't patients trust us? We have to be asking, what do we do to make ourselves trustworthy, right? Because what we've done so far is systematically lost the trust of communities. And so I think the onus is on us, not just as clinicians, but clinicians, as Lynn said, who are in a very complex social web of interactions, internally and externally. What responsibility falls upon us to become more trustworthy partners with the community?
I think that that is key. I've been thinking about that a lot as I move my work and my research forward. I'm a midwife. I work at Woodhull. It's one of the a midwifery strong organization. What are we going to do to build, to build out those relationships with the communities we take care of? Because the simple fact that we're located in a historically disenfranchised community, it's not enough. It doesn't make you a part of the community, right? It does literally, but it doesn't spiritually, it doesn't psychologically, it doesn't, historically. And so I've really been thinking about that. How do you reframe how we talk about trust? Because yes, of course, my interpersonal interactions with the people I take care of as a midwife, they matter. And it's why I'm a midwife, because we have a very holistic approach to how we care for people. And I'm in a system, as Lynn said, that is not constructed to allow for that kind of practice. And I think that that's really, really key. I think this work really demonstrates what we measure is what we invest in. And so if we continue to measure clinical, diagnostic, empirical things like yes, no, like Lynn was saying, right, or blood values or scans, values, and those, not to say those are not important, but where are we actually telling the stories of people who have lost someone? Where are we telling the stories of people who almost died giving birth to their child, right? I mean, I think that that's true in this pandemic time. Where are the stories of our grief and our loss? And can the system be recreated to use that as, I hate to use this term, but like a data point, because I'm on the MMR, as you know, and we mostly get these really robust charts of a lot of clinical measures and a lot of, diagnostic measures, and they're valuable because we do need to refine our practice as clinicians. But I don't get to hear the stories of people like Aya. What impact did this have on her and her partner and her, the grandparents of the baby? And those are the stories that I think as clinicians we need to sort of fill in even our diagnostic approach, because we're not addressing people's mental health care needs, we're not addressing people's social care needs, and it's becoming abundantly clear that those are also valuable metrics that we need to be thinking about in our care.
Yeah, I really like your response. I like that you said that what we measure is what we invest in. And I think that's why, the first panel talked about the quality improvement strategies that hospitals are undergoing. And this strategy was really to elevate the voices of the women and use their voices in those quality improvement strategies. So I appreciate that you really pointed that out. In addition to that, how do you think we can further integrate women's voices in the quality improvement work that's happening in maternity care settings? I know you're at Woodhull. Woodhull, is engaged in lots of quality improvement work. How can we begin to really integrate these stories and voices in these strategies?
I mean, to me, it's such a big question, and I think it needs to be a big question, and there needs to be a big solution or a big idea, because historically it's not how healthcare is designed. I think, like Lynn said, I really think about this a lot. The interpersonal is important, but it's also important that we think about this ecologically, right? That the system that we're embedded in, it doesn't capture people's stories. So, it might be something very pragmatic, like, is there a place in our clinical charting where we actually capture the stories of people that are beyond the, was it a planned pregnancy? Was it an unplanned pregnancy? What number baby is it? Or, did you have a prior morbidity event? And those are all, again, really important. I'm sure there's a lot of providers on the, on the conference, and I hope they're not clutching their pearls, but what are the spaces, and how do we operationalize and codify those stories as part of our charts? And it's not just an offshoot for the social worker, and it's not just an offshoot if that person happens to have a doula, that they're getting that kind of, intensive social support. But this is something that every person that we interact with is deserving of. And I think those are the big questions we have to ask, is how do those stories become part of our our clinical tool belt, and how do they become part of our shared experience? Because I think of care as a care provider and a researcher. I'm not just giving care, I'm in a care relationship with the person I'm taking care of, right? We're kind of in this together. And you also have to honor the power dynamic, right? That there is always a power dynamic. And so I really also want to think of us to use the term person-centered instead of patient-centered, because it's a whole full person that comes, like Nicole said, with history that is beyond their genetics or beyond their blood or their serum levels. It's a whole kind of lived and told history of who they are, and they bring that with them. And so maybe it is, about like, I mean, I don't know. I'm just throwing this out there. Like, is there a section in our chart where there is a storytelling interaction? Can we bring in oral historians that are part of our healthcare teams, to say that your stories matter, particularly if you've had a prior traumatic event? Because right now we're talking about the women who survived these near fatal events, right? Not the people who lost their lives from these events. So these are the people and the women and the mothers that can teach us what it means beyond the clinical, right? Beyond the how much blood they needed, or what gauge needle we should be using, or what treatments they need. But how do we take care of the whole person? And I tell this to my students all the time. When someone leaves my care, they should not leave my care more broken. They need to leave my care more whole, more complete. And that's where we're failing people. And maybe that's how we need to be thinking about our care. How do they leave our system more complete, more whole?
Yeah, thank you so much, Mimi. Making sure that, it's important that we look at the woman and the person giving birth as a whole person, and being more person-centered. And how can we make this part and parcel of the care that's provided? So I see a lot of nodding faces on the panel. Does anyone else want to add to that?
Maybe I mean, one of the issues I think is for us to really deeply understand that pregnancy, childbirth is not just a medical event, even though this is an SMM study and we're, very concerned about people's survival and that they're medically okay. It's a deeply social and political event, and it reflects many things about the person, their place in society, their family, all of these things. And so I think it's one of those moments in healthcare that we always have to think beyond just the medical outcome, the clinical outcome. And so thinking about a person as a whole person is thinking also beyond the event as a medical event.
Yeah, I couldn't agree with you more, Lynn. I mean, for ages, since the beginning of time, birth has been viewed as sacred, as ceremony. And I think that there's so much room here by listening to these stories to return the humanity, to return the dignity, to return the respect and the sacredity of birth, and in very simple ways. I've supported births where the person is pushing and they are in the zone, but outside of that space of where they're at, there are, say, maybe 12 other folks from within the hospital, and they're noisy, and, it's uncalled for. And, at the end of the day, it's disrespectful, and I think that's a very simple tweak. Like, we're birthing. It's a sacred time, a sacred space. If there's room for, in a non-emergent situation where things are perfectly fine, for folks to respect that this person is birthing and to silence. I don't think that that's a hard ask.
I mean, I only think the system, again, like somebody mentioned in the Q&A, Regina, that it's not designed to, even the limited time slots that we have to do complete, perinatal care visits, and the amount of, people you might need to see in a clinic day. These are all system limitations that are placed on building out a robust relationship between a provider and a client or a patient, right? So for me, I want to see the same person over and over, right? I don't want that person to be seeing other providers. And I think that is something we don't talk about enough, like continuity of care. That matters. And in these interviews, these women were talking about that they were seeing different people at every visit. And that does make a difference, because when I see the same person for 10 visits, I get to know them. I make it my priority to get to know them as a technique to improve safety, right? And so I cannot help but shout out the midwifery model of care. Nobody owns or should co-opt the language around sanctity or dignity. Like that is, like Nicole said, that is the foundation from which all of this should arise. And we have it inverted, right? We're trying to lay on this kind of respect and dignity on top of something that has so lost its way that I am with Nicole on this. We need to actually start from the ground up. Like the roots of this, of birth, are through the midwives that were in the community, that knew their community, that were caring for them. I think the other value, I just want to shout out Nicole and Oriana as interviewers who are part of their communities, you know, and it made a difference in reading those interviews. It makes a difference who is giving the care, who is doing the research, who's designing the policies. It all matters, right? And this to me, this project, my participation in this project was like that. This really, it solidified how important it matters in research as well.
I just wanted to say quickly, because I think coming from my everyday work, which is home visiting, if you guys, I'm sure, know about family, nurse-family partnership, and that home visiting model. And I'm hearing the word holistic, and I'm hearing the word historical and what we have and haven't done. And I'm old enough to remember when a doctor used to come to your home and there were home visits from your doctor. And I don't necessarily want to debate about what is and isn't realistic, but maybe there is a world where at least one prenatal visit could take place in your home, right? We're not going to do an ultrasound in someone's home. But speaking of holistic, speaking of knowing the community, speaking of what mom is dealing with, what better way to get to know that than to go to their home, if it's something that they are okay with, of course. One of the main reasons why I'm able to help the clients that I've been able to help, and why we at my organization are able to help the clients in the way that we're able to, is because we go to their home. We're able to see exactly what they're dealing with and what they have access to, what they don't have access to. And so that it makes way more sense for us when we're asking them to do certain things or suggesting that they do certain things and they are not able to do them. So just an idea, again, looking back at our history of what we have and haven't done, and that is something that used to be part of medical care.
So, Lucky, can I make a quick point building on what everyone said?
Sure.
I think we need to hold two things in play at the same time. On the one hand, we have to be thinking about these individual relationships, the sort of just what Oriana was just talking about, what Nicole was talking about. But we also have to simultaneously step back and see this as a big political, reproductive justice policy issues. Mm-hmm. So we need to simultaneously deal with the interpersonal in all the ways that my colleagues were just talking about it. But we can't forget that these are also big justice issues with systemic challenges, with political challenges. And I think it behooves us to do both at the same time, to keep them both in play.
Yeah. Well, I cannot thank you all enough for all of your knowledge and all of the expertise that you brought to this panel. You know, I have learned a lot just in terms of listening, communicating, reframing the way care is provided, providers being more trustworthy to their patients, and starting to think about how we can transform the way in which maternal care is delivered. So I would like to thank you all again, and invite Hannah Sarin to move us into our Q&A session. Hannah Sarin, you're muted.
Sorry. I just said thank you. This was a really elucidating and really very, very interesting. I really enjoyed this panel a lot. I'm sure a lot of others did as well. Just invite people to drop your questions into the Q&A function. Here's one question that's come up. So both Mimi and Len were talking about a midwifery model of care. So the question is, do people have ideas on ways to institutionalize the midwifery model of care in New York City?
Oh, I have so many ideas. I will say that, you know, midwifery, as kind of Nicole alluded to, is you know, a very, very old profession. I would dare say the oldest profession among human civilization. And I think the fact that it is right now, it's in sort of a marginal place, right? So in the US, about 10 to 12% of all births are attended to by midwives. And so that we have to take note of that and what the historic roots of that are. And I wouldn't be a midwife if I didn't mention medical patriarchy as being sort of a driving force in how the current healthcare system is shaped, right? And that's directly rooted into people's ability to bear children, and who is able to attend to that sort of sacred event, to use a term Nicole introduced. And I would say the bigger question is, how do we integrate midwives into systems of care? So right now we have various hospitals throughout the city that have midwives integrated on a range, right? In some places where they're very high functioning, very well integrated, meaning they're doing a continuity care model, they're providing person-centered care, all the things that our model is based on. And then you have places where it's sort of a few midwives are sort of dropped in. I wouldn't say that that's an integrated model of care, right? So all of the studies that we see, all of the evidence that we see, there was just a recent article in the Lancet about if midwives are well integrated, and that means the very first point of contact for everyone seeking out their primary maternity care needs is a midwife, regardless of their risk, that you could significantly drop mortality, morbidity rates in the 30 to 40% range. That is huge. So what is preventing us from picking up and investing in that model? To me, that's medical patriarchy. That is what's preventing. It's the culture of power that's within the medical system that is preventing the uptake of this model. And there's also a workforce. We don't have the workforce, right? We don't have a representative workforce to care for people in the public health system. In New York City, H&H, I will say, is a leader in using the midwifery model. It's integrated to various levels, but I would say we need federal mandates, we need state mandates on every facility. I'm getting passionate, I'm getting heated. Every facility providing integrated midwifery care to every single pregnant person that they are taking care of, regardless of risk condition, right? Because risk conditions, like in Europe, are managed by obstetrical specialists. Obstetricians are not laborist, or they don't take care of straightforward pregnant people. You transfer them when a person develops a risk condition. In the US, we have that model inverted. And so, there's many answers, but I had to sort of jump in on there and offer because this is my area of research. So.
Thank you, Mimi. Are there other people who want to comment on that? Okay. So there's one suggestion about how we might do this at the hospital level. So perhaps adding some questions related to SMM to patient satisfaction surveys at the hospital level to be shared with the Department of Health at the state level, like around what we do with safe sleep practices that could be used for monitoring. What do people think about that? Or is that one way to measure? Do people have other ideas about how we might measure this? I know Mamie talked a lot about the importance of measurement, but how could we actually operationalize that?
I'm just going to note that Christine Morton has put some information in the chat that may go to that a little bit, and talks about a tool, support after a severe maternal mortality event safety bundle from AIM, that I think makes space for these stories. If I'm quickly reading the chat correctly, I guess.
Yeah, and I think
Yeah.
there are metrics that are validated, and there's the Mothers on Respect Index that could be integrated into because remember, if we just keep measuring outcomes by clinical data, which the traditional ones are, cesareans and episiotomies and APGAR scores and NICU admissions, which are sort of yes, no, 0, 1. You miss the nuance and the texture and the fabric of people's experiences. So there are, my PI Saraswati Vedam has created the Mothers on Respect Index, the Autonomy and Decision-Making Index. So there are validated tools that we could be, if we want to really measure this empirically, there are tools that exist. But what is it going to take for the systems to uptake those tools? I think has to be a very concerted global effort of multiple stakeholders saying, this matters to us, please see us, please listen to us. And who are the decision makers at the systems level and the hospital level? And to me, it's like the Greater New York Health Hospital Association. I mean, it really is kind of like the top has to listen to I hate to say the bottom, but you know what I mean? It's not the bottom. The people who are making the decisions have to listen to the people who are the service users and the service providers.
So Oriana mentioned this brain tool. Are there other lessons or tools that other panelists might pass on to women or community members listening today on how they can advocate for more person-centered care with their providers?
Well, one thing I'll say is, I think something that this conversation highlights is the need and the opportunity here to integrate different workforces that have already built in, people-centered isms into their work. So I'm thinking about the midwifery model of care. I'm also thinking about other birth professionals like doulas. Built into the work that we do is learning who our people are. A lot of us as doulas, what we tell our folks is, the main purpose of our meetings prenatally is for us to get to know each other, and so that's one thing. I think that, we can absolutely begin to address the need for more interpersonal and just a deeper communication between patient-provider interactions by integrating some of those various workforces. And the other thing that's coming to mind with folks and working with doulas is that, part of what we do is we encourage people to become stronger self-advocates during our work with them prenatally, So in an ideal world, it's not the scenario where doulas have to serve as the advocate, because one, there should not be anything that someone needs to defend themselves against. But unfortunately, the situation is not that, right? So first line of defense should be the individual, the person, who is undergoing the experience, and that they have built up within themselves the tools that they would potentially need to self-advocate. And working with a doula is one of the ways that they can strengthen those things. So doula support is something that I'm a proponent of.
And just to add to that, the health department is working with 14 hospitals across the city, and they're working with birth justice defenders who are community members that build advocacy for respectful care in the community. So these birth justice defenders work with women of reproductive age to help them, build self-efficacy for advocating for better and respectful care.
I just wanted to add to Nicole's point, for those moms who maybe sometimes don't have a doula, or they do have a doula, but oftentimes they'll have a partner who is invested and interested in being part of the journey. And at my job, in my office, we have heard of dads especially who are dismissed by the people in the room, sometimes not even eye contact. So I think that if there are providers out there listening, I think the other thing that I would advocate for, in addition to not only being accepting and encouraging of someone like a doula, also of the partner or the support person that is there for mom, who is very much invested in being part of the journey.
I think it's also important to recognize on the facility side that it's not only the clinicians with whom patients interact. So there are many other people in the staff at the hospital who are also, part of the patient experience. And I think, I'm not sure whether the QI process often moves beyond the clinical care, but I mean, people throughout the staff are sort of experts on the system in which they work. And it may be that opening up or thinking about how that system works beyond just the clinicians, and recognizing also that people are interacting with a whole range of staff at a hospital is part of thinking more broadly beyond just the patient provider, patient clinician relationship.
And a lot of the interviews, the participants were talking about the nurses as well. Mm-hmm. And I really want to bring them, my fellow nurse. I am a nurse. It's so important, and it's a workforce that doesn't get sort of integrated into this work, and it's really a shame, because if we think about person time, even COVID is showing this too, 80% of person time, I'm talking about bedside care, face-to-face care, is with a nurse. And we need to be working with, talking to, being led by all of those things by nurses who are also, to me, again, in the medical patriarchy, they become kind of squashed and sat upon. And so what are we doing to kind of work with nurses and really have them kind of be a part of this justice and equity movement? To me, we're not doing enough. But they are 80% of the workforce of who is getting care of in the hospital. So that's 80% of our focus. It's not being directed in a way that could create some real substantive sort of justice, equity-oriented professional change.
Great, thank you. One last question. One of the people in the audience talked about how a traumatic birth can lead to health complications as well as mental health complications. So this person asks if there are ideas that any of you have about how we should be addressing the mental health implications for perinatal women.
Go ahead, Aya. I think you're muted. Your mic is muted. Yeah. Okay. Anyone else want to take the question while I?
So well, hopefully Aya comes back, but again, speaking to my experience working with a home visiting program, something that we do that is a validated tool, to sort of speak to Mimi's point from before, it's something as simple as a PHQ-2 or sometimes the entire PHQ-9. Sometimes the Edinburgh can be even a better tool for that, but it's sort of something that we are able to do. We're not nurses, we're not medical providers, and it still gives us very good and critical information that we need so that then we can follow up with mom and, you know, talk to her about what her options are, because of course it also depends on, sadly, you know, does she have health insurance, is she undocumented, et cetera, understanding what her options are and sort of helping to guide her. Okay.
Yeah, I think Aya's back on.
Okay, there's some echo. You can hear that too?
Yeah, I think it's, you have two devices on.
Right. Yeah.
So I think if you maybe mute your phone or mute the computer, try muting the computer and then talking through your phone.
Does it work? No, I'm sorry.
That's okay.
It's okay.
Sorry, we can't hear. Okay, so I think we've come to the end of the panel. Palaka, if you want to, do you have any?
Yes.
Yes. Okay.
So yeah, just once again, thank everyone on this panel for really sharing their experiences and also bringing their expertise to bear in answering those questions. I can see from the chat that everyone's really engaged and you know, discussing the things that have emerged from the panel. So thank you all, and yeah. That's it.
Great. Thank you so much, all of you. That was wonderful.
So
that was a really difficult panel, hard. It may have triggered some emotions. And so remember, at the end of the day, we're going to have a space for people to go and gather and kind of release and process a little bit. And I encourage you now, we'll take a break. I think until it's 3:30. So I encourage you to just stretch. If you feel the urge to tweet, please do, and chat with each other, get each other's emails, interact. So thank you all, and we'll see you back at 3:30.
Thank you.
Thank you.
Hello again. I'd like to come back now after this second break, and we're going to start our final panel before we get to our call to action and wrap up. Before we do, I would like to say thank you to two people that I missed thanking at the beginning. That's Mr. Michael Klitsch and Miss Veronica Murray, who were amazing in helping us pull together the presentations and graphics and all the toolkit itself. So thank you both very much for your help. So now I would like to bring up Hannah Empel, who's going to be leading our third panel, Miss Hannah Empel. And she has, I see her camera on. Miss Empel is the Deputy Project Coordinator for the Severe Maternal Morbidity Project at the New York City Department of Health and Mental Hygiene. As Deputy Project Coordinator and previously as the Data Engagement Specialist for this project, she has been responsible for implementing a range of community engagement strategies, including conducting public presentations to disseminate data on maternal health and developing social media projects. Prior to her work in New York City, Ms. Empel worked at the Center on Social Disparities in Health at the University of California in San Francisco on projects addressing racial disparities in maternal and infant health outcomes in California, and before that in Washington, D.C., at a national public policy think tank focusing on wealth and equality. Ms. Empel holds a Bachelor of Arts degree in Geography and Community Health from the Macalester College in St. Paul, Minnesota. She has experience as a birth and abortion doula and has volunteered as a harm reduction outreach worker with people engaged in sex work and drug use. Ms. Empel.
Good afternoon, everyone. Thank you, Hannah Searing, for the introduction. It's a pleasure to be here today. So I'm Hannah Empel, and I'm the moderator for today's third panel session, which is exploring innovative engagement strategies for engaging with community members on information related to maternal health. I'm very excited to be here with a group of panelists who I know are all working on logging in. We've had some tech challenges today, so bear with us all as we get everyone up and running. I first want to thank and recognize our entire project team here, led by our director, Hannah Searing, our other Bureau of Maternal, Infant, and Reproductive Health and Division of Family and Child Health teams, and many other New York City Health Department colleagues. In particular, Sharon Marshall-Taylor and Eilish Neely, who contributed many, many hours to the outreach for this program. And I'd also like to especially honor the contributions of Kelly Davis, without whose vision and tireless work, this project would not have had the same impact. Before I turn it over in a few moments to our panelists, I want to share some background information on how the Severe Maternal Morbidity Project approached community engagement work. This project recognized early on that community members have been sounding the alarm for years on the high rates of maternal health complications. As has been a theme throughout today's sessions, communities of color in New York City and around the US, but particularly Black people and their communities, experience a disproportionate share of maternal health complications. This is due to the pervasive and systemic impactism that permeates our society at every level, from interpersonal interactions to the structural level, where neighborhoods of color experience chronic neglect and disinvestment from both government and business alike, and to the societal level, where a pervasive culture of white supremacy dominates our economic and political landscape. This multifaceted system of racism creates stressful conditions for nurturing healthy pregnancies. It diminishes equitable access to respectful maternal health care, and it makes it harder for families welcoming a new life into the world. The underlying inequities in our society show up in maternal health outcomes here in New York and beyond. Our team set out to share information about maternal health and specifically severe maternal morbidity and related inequities with the community in a way that was accessible, useful, and could support existing community action or seed new efforts. We wanted to help people connect the dots from racism and structural inequity to maternal health, and to see that outcomes in their friends, families, or even themselves were not the result of individual choices or behaviors, but rather a reflection of our society's failures. So the goal of our project's engagement activities was really to mobilize, inform, and validate. To mobilize community members to use available data sources to advocate for themselves and their loved ones, to inform people of their rights before, during, and after pregnancy, as well as to inform them of the pervasive nature of maternal health inequities, as well as possible solutions and the important progress that is being made. And then to validate the lived experiences of members of our community who have come dangerously close to losing their lives giving birth, or have in fact tragically died from maternal health causes. When we talk about the data on maternal health, it can be easy to forget that each number represents a person, most significantly the moms who died or almost died giving birth, but also the partners, the children, the other family members left behind. These numbers can also hide the clinical and support teams who work so hard to care for their patients and then have to live with the trauma that comes with a death or a near-miss event. So this panel today will focus on several interrelated questions that we hope the audience will consider as we go through. What strategies can be used to engage with community members on improving maternal health? We're all here today representing different communities, organizations, professional backgrounds, and each of us probably has a different way that we would think about presenting information and would be able to make successful inroads with different groups of people because of our varied experiences. How can clinical partners in particular engage with the community to improve maternal health? Clinicians have consistent, regular interactions with their patients and have the potential to reach people in the midst of life-changing moments, but how can they, how can they use their expertise to go beyond the exam room? How can community advocates and researchers use data in creative ways to engage the public in maternal health work? It can be hard to distill key messages from complex data sets, but it's worth taking the time to think about what's most critical for people to know and how they can be communicated in a way that actually resonates. My hope is that everyone can take something away today that inspires them in how they would approach community engagement work going forward. Before I introduce our panel, I would like to share some more detail about our engagement activities. One of our primary engagement strategies was a so-called Data to Action Roadshow, during which we conducted over 20 public presentations. This was all prior to the rise of COVID-19, where data and information were shared in a thoughtful way with community members. The bulk of those meetings took place in the setting of community board meetings, and shown here on the slide is the outline of New York City's 59 community districts, which each have a corresponding community board. The rest of the presentations took place in other meeting environments, such as at events hosted by nonprofits, and even internal presentations at businesses or universities. We relied on existing Department of Health relationships with the community boards and built new relationships with partners along the way. This slide also shows a flyer developed by our team for distribution at these presentations that shares a few key facts about severe maternal morbidity, as well as information about Department of Health resources. There's a photo of me doing one of the presentations. At that particular presentation, I was actually joined by a colleague representing the Birth Justice Defenders, which was referenced earlier. This is a partnership between the health department and community members who are interested in improving birth experiences and outcomes through community-led mobilization efforts. One of our panelists today, actually Ann Housen, is a member of this group, and she will later be talking about some of the strategies that the Birth Justice Defenders have used to advocate for safe, dignified maternity care. I've also included a flyer from a community forum that took place in Brooklyn that was planned in part as a response to a presentation done through this project at a community board meeting. And Francisca Leopold, who you will be also hearing from on the panel today, is pictured here speaking at that forum, which she planned. For each of the data to action presentations we prepared for, we considered the specific audience. What were their needs and interests? What information would be most relevant? What hyperlocal context would we need to consider? We used all of this to modify the presentation each time. The goal was to share data on life-threatening maternal health trends, to give people a sense of the scope of the problem of severe maternal morbidity, as well as discuss how and why racial disparities exist in maternal health. Each presentation was bi-directional with plenty of time for questions and discussion, and we got a lot of wonderful questions, thoughtful stories, plentiful anecdotes about how this topic had affected people's lives. We always began the presentation with a content warning because we knew how many people would have their own personal experiences with the topic of maternal health complications. And we ultimately were able to reach hundreds of people with these in-person presentations and the subsequent discussions. In addition, funding from this project supported the work of several bloggers and social media influencers who created unique online content related to maternal health inequities, either highlighting data, personal experiences, or both to reach community members digitally in a nuanced, culturally relevant, and accessible format. Nellie Acevedo, who's a member of this panel today, is featured in the image on the top left. You can find her work online at brooklynactivemama.com, where she blogs about fitness, parenting, food, or on Instagram, where she is at glamnelly. Our other contributors for the Social Media Influencer Project were Cece Olissa, who is a model and the founder of CurvyCon, an event that brings together fashion, lifestyle, wellness brands that all have a focus on plus-size women. Celie Racio, an author, blogger, and a national advocate for equitable policies for mothers. Carmen Mojica, who is an Afro-Latina, Bronx-based midwife and doula who runs a blog and a Facebook page called These Waters Run Deep. And Ancient Song Doula Services, a Brooklyn-based full-spectrum doula service organization founded and led by Black women. We wanted to develop projects with influencers because we realized that just as it is essential with in-person outreach to meet people where they're at, both literally at a physical location, but also in a style that's appropriate and with a relatable approach, all of those same principles apply online. Each of the 5 influencers approached their project with us in a different way. So for example, Nellie blogged about her experience preparing for her 3rd birth and how her conversations with her doctor beforehand gave her confidence before her daughter was born. Meanwhile, Cece talked about how, as a plus-size Black woman, she encountered bias from her care providers when she sought out care. She explained that the focus on her weight really distracted her providers from focusing on what her actual underlying problems were. Some of the social media projects also focused on disseminating information on key maternal health warning signs about preeclampsia and postpartum depression in particular. You can learn more about our approach to social media as well as the Data to Action Roadshow in our chapter of the Severe Maternal Morbidity Project Toolkit on innovative engagement strategies, which is available online. The link for this set of resources was shared earlier today in the chat box. We built these partnerships with the influencers and were ultimately able to reach tens of thousands of followers in a likely more organic way than an institutional or purely clinical account would have been able to. So today's panel will feature people who contributed to the project in direct and indirect ways. Each person is an impressive advocate in her own right, with community contributions in multiple different venues. I really appreciate that each of them was able to make the time to join us here today and hope that everyone has successfully logged on. We'll check in on everyone's status in a moment. Panelists, you can go ahead and begin turning on your cameras and unmuting at this time as I read through everyone's bios. So first, Francisca Leopold is very active in her community. She is a member of Crown Heights South Community Board 9, where she serves as the 2nd vice chair on the executive board and chair of the Health and Social Services Committee. She also serves as the second vice chair on the Kings County Hospital Review Board and the co-chair of their legislative committee. In addition, Ms. Leopold is the founder and president of Lefferts Alliance Community Togetherness Block Association and the founder and an honorary member of the Clarendon Cortelyou Roadblock Association, both of which are based in Brooklyn. We'll also be hearing from Nellie Acevedo, who is the founder of the award-nominated BrooklynActiveMama.com, a platform dedicated to providing recipes, printables, and fitness tips for busy moms. She uses her platform to women with the tools to cultivate their best selves. Ms. Acevedo shares pregnancy tips and her own personal motherhood journey as a busy mom of 3 amazing kids. And panelist is a Caribbean American mother of 4 from New York, where she has been in for over 30 years. She holds a in psychology from Brooklyn College and a master's in public education from Metropolitan College of New York. Ms. Housen is a Brooklyn birth justice defender, a member of the New York City Maternal Mortality Review Committee, a committee member of the East New York Community Land Trust, a community and public health advocate, in addition to being an independent consultant. I'm now going to turn the conversation over to our panelists and begin with some questions. At any time while the panelists are talking, we invite you to ask a question using the Q&A feature on Zoom, and we'll take as many questions at the end as we have time for. And we also, of course, invite everyone to share their thoughts now or later after they've had time to digest on social media. Feel free to use the hashtag NYC Mat Health Summit so we can all engage with each other online. And at this time, I'm going to check and see how our panelists are doing getting connected. Looks like Nellie, can you?
Yeah, I'm here.
Great. And Anne, I see you are there. Fantastic. Thank you both for joining me today.
Of course.
While we're waiting for Fran to join us, I'm going to ask Nellie to get us started. Can you tell us about your blog and your social media work for people who don't already follow you, and describe kind of your online presence, your brand, and then we can get into the specific contributions that you made to the Severe Maternal Morbidity Project.
Okay. Well, hi, everyone. I am Nellie Acevedo, and I am Brooklyn born and raised. I am a content creator and a social media strategist at BrooklynActiveMama.com. I have been working on my website and working full time for my website for the past 5 years. I have an amazing audience. I have an amazing community, over 60,000 women, and we share so much every single day because every day is different, especially in 2020. So I share recipes and printables and pregnancy information, lots of fitness tips. I am a runner. I run 2 marathons, and that's what I do on the internet.
That's awesome. And can you tell us now a little bit about how we originally got connected and the work that you first did with us back all the way now in 2018?
Yes. So in 2018, I had my 3rd baby, which is my daughter, Jasmine. And she, when I was pregnant with her, I was able to hook up with the SMM team and share with them how I was able to create a plan with my doctor to make sure that no matter what happened during pregnancy or what happened during the birth, I knew I had a strong plan to make sure that everything that I needed to have happen go right. So I even had a backup plan with my husband. I had a backup plan with my mom. And up to that point, it had been a long time for me to have my daughter. So the difference between my last kid is 6 years. And so I knew that there was a lot going on. I had seen a lot going on in the community about Black moms and pregnancy and everything that's happening there. And so what we were able to do with SMM was I created a blog post that shared my plan with my doctor. And I also happened to be nominated for an IRIS Award, which is like the Emmys of blogging. So that was pretty cool. And basically what I did was I shared my plan with everyone, with my entire audience, about what was going to happen after I had my baby or during my birth process, my birth plan. Everything ended up going well, thank God, but I also was able to go in there informed, and I also was able to know exactly what I wanted. And I was also able to share lots of information with my husband and my mom so that they knew that if anything went any other kind of way, they knew how to be prepared.
Thank you, Nellie. That's really helpful. So can you talk a little bit about the process then of developing sponsored content with the Fund for Public Health and the Health Department, and how that went? How was it the same or different from your other types of work? I think, for people listening who maybe are not familiar with how sponsored content works, really nitty gritty of what exactly you partner with, typically a brand, more corporate entity. How is this similar or different to those types of partnerships?
Well, this one, I do have a lot of brands that I work with on a monthly basis, even a yearly basis. Some where I work with them on a brand ambassadorship where I might be doing lots of different content every single month. And some where I do a one-time, maybe it might be an Instagram story or a Instagram post. For this one, I was able to do the full shebang. So it was a blog post, it was Instagram, it was Twitter, it was Facebook, it was all of that. What made this one different was that it was very personal, right? So I was able to share a lot of me, and I was able to also incorporate my concerns for all Black women and all women of color who are about to have babies, and maybe include some things that they were able to look for, things that they were able to think about beforehand, things that I maybe was not so aware of in my first 2 pregnancies. I was able to kind of bring that to the table with my 3rd pregnancy. So working with the fund was awesome. It was fantastic. It was a very personal experience, and I got a lot of amazing feedback from my community. We all had a very deep conversation about it, on every single platform, whether it was Instagram, whether it was Facebook, Twitter, we all were talking about it, and there's different communities on each platform. So it was really cool to see everyone come together on this one topic.
Fantastic. Thanks, Nellie, for recounting all of that. It brings me back. Let's pause for a minute. I want to bring Anne into the conversation. Anne, can you just tell us a little bit more about yourself and the work that you do with the Birth Justice Defenders? So for anyone that doesn't know already about that group, talk to us about how it came about and what your role has really been.
Okay, hi, good evening, everyone. My name is Ann Howson. I am from Brooklyn, and I'm also a member of Birth Justice Defenders. I came about being a member of Birth Justice Defenders by one of my college colleagues named Suzette Jules Jacks. She is the founder of Hope and Healing Family Center. And one day she told me about a group of people who were concerned about the high rates of Black women in our community, especially East New York, where I am from, passing away from childbirth. So that piqued my interest. And so I continued to go to the meetings, and I like the message and the mission that Birth Justice was trying to tell the community. And I was happy to be one of those community members there. And it also spiked my interest into other things in my community as well. Birth Justice Defenders are a team of community members who are passionate about birth justice and seek to educate their communities about and advocate for the rights of individuals to just, respectful, and dignified care during pregnancy, birth, and postpartum. Birth Justice Defenders conduct community outreach and education about the New York standards for respectful care of birth, thereby increasing community awareness of best practices for respectful care at birth, and to aid in collective ability to effectively advocate for rights and related to birth justice. And so that's what birth justice is about, mostly like the education of community members in the community about the epidemic of Black women passing away from childbirth. And also to highlight the New York City standards of respectful care at birth, which is like an affidavit which women can use to explain their rights as they come into the hospital to give birth or before birth as well.
Thank you, Anne. That's an incredible overview. Can you talk a little bit about what birth justice means to you personally? Like, what really brought you to this work?
First, I'm a woman. Also, I'm a mother, and also I'm a Black woman. So I connected to all 3 points that was given to me when I was introduced to birth justice offenders. And through the experiences of going to the hospital and feeling intimidated and knowing that at times that my words weren't being heard or I wasn't being understood. And in that could affect my birth. And in those cases, it has affected many other women's births just like me. So that aided me into wanting to advocate for other women who may not want to share their stories, but feel comforted by others like me, myself, in the community to share their stories to get help for other women and make people who should be accountable for their actions. So that's what birth justice means to me. Making people accountable for their actions in the spectrum where it comes to birth, whether it's women, whether it's the family, everything included, because that's important for us as women and also as our community to advocate for women, the justice in that, to find the justice in that. Yes.
Thanks, Anne. I think the word that I just really picked up on was accountability. Can you talk a little bit more about your role on the New York City Maternal Mortality and Morbidity Review Committee and kind of what you see as kind of the relationship between that and what you do with the birth justice defenders, and, you know, maybe share with us some insights that you've gleaned from being a member of that committee, while of course respecting the confidentiality of that group.
Right, exactly. Well, through being a community member, I was given the opportunity to be a member of the M3RC committee. And with that committee, we review the cases of women who passed away from childbirth, mainly to implicate to see if there was any implicit bias occurring during the span of the woman's pregnancy throughout her birth. So we really comb through the social, through the medical aspects of the woman's life, however much information we're able to get as the committee, and comb through to see if there was any anomalies that could have contributed to her death. Whether it was implicit bias, whether it could have been her health, diet, community, environment, things that she wasn't knowledgeable about that contributed to her death. And so we as a committee of doctors, administrators, lawyers, community members like ourselves, review these cases and hope that from reviewing these cases and seeing with our eyes that we're able to let other officials know that there's things that they should be looking closely about that we as a committee see that could be aiding to these women passing away at these high alarming rates. So that is the accountability portion as well, with me being on this committee, to ensure that whatever that we pick up on is being able to be communicated, transmitted, and create a solution to the problem.
Yeah, thank you. I want to ask you both, and Anne, we can start since you're already speaking. Can you tell us, what do you think is the #1 issue related to maternal health that's facing the communities that you represent and work with?
One of the major, it's a lot of issues that like contribute to this issue. It's like there's more than one issue, but I could say one is the implicit bias, that for one, and also I'm sorry, I'm nervous today. I'm sorry.
That's okay. We can also pause and always come back to that question.
Yes, you could pause and come back to this question, but I could say for one thing, I know it's implicit bias, and also my feeling is empathy, and the connection between the doctor and empathy towards the opposite race. Like there's no connection between the doctor and the patient when it comes to Black women and a physician, or an administrator and another Black woman. There's no connection there. So the way how things are communicated is not reciprocated on both ends, and also with empathy as well. But I can come back later to that question if you like.
Okay, that was great. I mean, that's plenty of material right there. Nellie, do you want to take a stab at talking about that? What do you think are the biggest challenges?
Yeah, for sure. So I guess when I shared my original story, and since I've been sharing more on social media in the past couple of months about pregnancy-related issues and so forth, the most thing that I've heard the most from everyone on every platform is that Black women are just simply not being believed. So everything that, mostly everything that they're saying or that they're sharing with their doctors or with their healthcare providers, is just either being brushed off or just not being, taken seriously enough. So that seemed to be the common thread. And unfortunately, a lot of these issues are not taken seriously until it's a very serious issue. So, it's very important that our healthcare providers start to listen to Black women and understand them and take them very seriously, whether it's a very small issue or a large issue. That seemed to be the common denominator amongst the people who were commenting and even emailing and sharing their stories with me.
Yeah. Could you help us think through, since we're looking here today at different ways for clinicians, the health department, maybe people working in other jurisdictions to communicate with the public, what do you think are the most effective ways to reach people? Would it be through, partnerships with people like yourself? Are there other strategies that you've seen that are really effective? Talk to us about, what you've seen and what you would recommend for future, opportunities, whether it's a funder who's thinking about this or a public agency or a nonprofit, any kind of group like that.
Yeah,
how should they go forward?
Yeah, so I would absolutely recommend that they work with social media influencers and content creators like myself. We have our own audiences. We reach people that most people can't reach, and especially look for those types of content creators that are real and genuine and share their own stories with their audiences. There is a special connection there, and they are most likely to listen to them versus, reading something on the internet. Another thing is just making sure to share real stories. I think real stories is really where the meat of everything is. It's one thing to hear that this is happening everywhere, but when it happens to your cousin, when it happens to your sister, when it happens to your friend, then all of a sudden it's very real to you and you become an advocate for these types of issues. So I think it's very important that not only are they reaching out to content creators and so forth, but that they're sharing real stories of what's happening and how that can actually connect to someone who might be pregnant right now or someone who has gone through it. Because once you start sharing stories, other people want to share stories. And even on the little social, I've been sharing social media information about preeclampsia and things like that. And the comments that I've been getting and the direct messages that I've been getting are a lot of thank you for sharing this because I didn't know what this was, or thank you for sharing this because this happened to me and I didn't know what it was until I got to the hospital. So I think it's important to share real stories. It's so important to just make sure that, yes, we love the statistics, it's awesome, but we also just need to know the other side, the human side of it.
Thanks, Nellie. Anne, I'd like to give you an opportunity to respond to that as well. And then after you give your remarks on that, we're going to welcome Francisca Leopold to join us. She's just getting on now. So Anne, we're thinking about, effective ways to communicate with the public. Do you have any thoughts about that, about things that you've seen at work or don't work, and how could social media improve things?
I agree. We're in a new age where technology is very different. The way that we communicate as individuals have changed. And so I feel that people now are more comfortable communicating with each other on social media. So to gain their attention through social media will be mainly effective because that's where most of the people are spending the majority of their time. So I think social media is effective. It's just the way how you go about with social media. But I do feel like social media and having that, your followers as well, what she was saying, to have your own personal followers who are following your own stories, your own experience, and connecting with you personally so that they can feel comfortable and kind of let some types of guard down so that they can speak to you about their actual lived experience, to know that they're not the only one. And if they have not experienced that, at least they are given a story about an experience that can happen to somebody, and that they can have empathy for that person, from hearing their stories. So I feel that it's very important for women or families or anybody to share their stories, because you're not the only one who's experiencing these things in life.
Oops, looks like maybe Anne got cut off there. And feel free to jump back in when you get a chance, but oh, there you are. Okay.
Sorry. Can you hear me now? No, the connection.
Yep, we can hear you.
Oh, okay. The connection to our births is connected to something bad. So no one talks about these births anymore. No one's talking about the life or the past births. And I feel that we as women need to get connected so we can all mourn and support each other through these moments. I feel like we're becoming disconnected and not connected. And as we disconnect, we're not finding that support. And that's what we yearn. We yearn that support. So being on social media, however way that you feel comfortable in gaining this information, I say go for it, because this is where we want to gain our members, our community members, people in the community, people out there, wherever they are. This is the platform where, one of the platforms I want to gain the interest of others and to share information and knowledge.
Yeah, I totally agree. And I think that connects so well to the panel that just happened before this one about the importance of storytelling and how listening to people's stories and giving them even an opportunity to share that can be extremely cathartic and healing for people. So
right, and empathy too for those who don't go through it. What about men? Men do not give birth. However, through them repeatedly hearing these stories, it creates empathy. So now they can put their feet in your shoes and understand what you're going through. So then you have another supporter who understands what you're going through, who may not look like you, but can understand what you're going through. And here's another advocate who's on our team. So having people explain their lived experience is more or less like you're telling people to be understanding of you so that you don't have to feel vulnerable, because it happens. And we have people like myself, like the other people on the panelists, who's here to help you with those resources and tools. So you don't have to transition and go through those issues on your own. And that's why we're here, to spread that message to all, to everyone who's willing to learn, to understand that this is not a not serious issue, it's a very serious issue. And that's why we're all here today, to let everybody know that you can't take this very simple. So this is like a call to action, with social media, with having these panel discussions to let everybody know that Black women in America are like an endangered species right now, by the hands of hospital administrators, by people who are not empathetic about our pain, our birthing stories, us being here in the United States. People are not empathetic to us at all. So we need people to come out, women, families, fathers, cousins, uncles, grandparents, everybody to share some type of story to get everyone empathetic about the cause, to get more people on our team, to push policies to be changed, to make people more accountable, because we can't change every single person, everybody's thoughts, their behaviors, but we can make them very accountable by putting the law on them, you know? So it's like, that's why we need more supporters out there to hear our stories so that we can go out there and do the work that's necessary so that we can save the lives of our Black mothers. Our lives are important. Black mothers' lives are important. Just like our babies are important, our community members are important. Everybody's is just as important. So speaking about this, I'm very passionate about it.
Yeah, thank you, Anne. It's a call to action, and you're also calling us all in to contribute to this. So thank you for your work on this and for your words. I want to turn to our third panelist and see if she's able to unmute. And Miss Leopold, are you with us? Let's see if you're able to.
Yeah, I am.
There you are. Fantastic. All right. So we already did an introduction before you signed on, reading about some of the incredible work that you've done. But for everyone who's just seeing your face now for the first time, can you tell people a little bit about yourself, how you and I first got connected, and then we can get into the Maternal Health Forum that you planned on behalf of the Crown Heights South Community Board. Thank you so much for being here.
Yeah, thank you. And I'm so sorry I'm still having internet issues. And good afternoon to each and everyone, and to those who are out there looking in, and to the panel also. My name is Francisca Leopold. I live in the area of Lefferts Garden in Brooklyn. I work for the New York City Commission on Human Rights as an associate human rights specialist. In my community, I serve on the Community Board 9 in Crown Heights as the second vice chair on the executive board, as well as the chair for the Health and Social Services Committee. I also serve on the CABS as the second vice chair and co-chair of the Legislative Committee at Kings County Hospital. I'm a member of Council Member Matthew Eugene Task Force liaison for the community liaison for the 71st Precinct and president of my organization. So my involvement in the community is vast because of my love for the community, wanting to see the level of community, the quality of life in the community move from one level to the other. You want me to go into how we met?
Yes, tell everyone about how that process happened, about the presentation and how it led to the forum.
Yes, so in the summer of 2018, I think I'm right, it's 2018, the Health and Social Services, we hosted Ms. Marshall and Ms. Ample for presentation on maternal morbidity in Brooklyn at the Community Board office. And this is where my community meetings are held every month. And if I must say, boy, oh boy, it was an eye-opener. And the alarming need to bring this awareness to the community. And I so agree with the panelists who just spoke. I think it's Anna, and how she spoke about the awareness and educating the community, bringing out the message out there. Because if you and Ms. Marshall didn't come to the board and the survey that was being conducted in Brooklyn at the time, and coming into the community board to make this presentation, I would not have known of this crisis that was happening in the community. And after that presentation, that's when I went ahead and I organized the forum thereafter. At the table, with the conversation that was being conducted on that day, there was Ms. Hannah Ample from the Department of Health. We have Ms. Marshall from the Department of Health as well, and another colleague, Ms. Wilson from the Department of Health. We also had on the table, engaged in the conversation, Ms. Vera Apia Adjumont. I don't want to butcher her name. She's the director of maternity at Kings County Hospital. And we had Congresswoman Yvette Clark also present. And we had Ms. Sabrina Lewis from the NAACP, and she's the health for she's the chair for the community health. And I mean, we also had community residents, and the conversation, I must say that the conversation was very intense and emotional. And some of the conversation and the dialogue that we were having and experiences brought tears to my eyes, and it brought tears to other folks' eyes as well. And since then, we are due for another meeting, because since then people have asked for more dialogue on that issue, you know. And after that forum, I became very interested in the maternal health crisis in the community. And I must say that the reason that I become so interested is because of the community and the community that's present there. We have a wide range of Caribbean residents, and I must say a very, very strong Caribbean culture. You know, so therefore I think that awareness, because the culture in the United States and the culture from the Caribbean is completely two different. And then that awareness is needed in the community.
That's exactly what I was going to ask you to get into next. For people that are listening today that aren't familiar with Crown Heights or Central Brooklyn, can you talk about kind of more of the specific local issues that you think make maternal health so challenging for women and families and other birthing people in your community?
I think that with the non-immigrants, a lot in the community, and we have a lot of young people who are getting pregnant, and they're afraid of deportation, because some of the people, if the older folks who are getting pregnant, who get sick, it's not only pregnancy, but the general health on the whole. People are afraid to go to the hospitals. And even when we have meetings at Kings County, and it is one thing that they always stress, to let people in the community know, hey, non-immigrants, you're welcome. We're not going to call ICE for you. We're not going to call the police or try to deport you. And these are a lot of the issues, some of the issues that hold back people from going out there to seek the help that is needed. Then also we have people who are uninsured. Some people, they are not working, you know, and some of them, they don't know and they don't have the information needed as to how to obtain insurance. There we also have language barrier, you know, and although I know that, but it came to bright light and just flash during the election time. You know, you're talking to people, you're having dialogue, and then you just have a short dialogue and then they leave. But then when you were there and then we are having a conversation and then you're given directions, and then the very same thing that you would have told this person, and the person say, yes, I understand. And then they would come back 2 or 3 times asking you the very same question. And that really just did it for me. I said, it is an issue. So when it comes to the health care, when it comes to you going out there, and then we have and for those who take the time to go to the clinics, you know, to seek help, to get the services that they need, sometimes the information that is given to them, some people, they don't want to say, oh, hey, I don't understand what you're saying. You know, they will just yes you to death, and then they will live there and go confused, you know. And another thing that plagues the community also, I'm not in a negative way, but it could be negative as well, detrimental as well, the deep Caribbean culture, that deep-rooted culture, you know, parenting. And I call that on some of the deep culture back to Eden, because the reason why I call it back to Eden, because I as a young woman, a young girl, I grew up in the Caribbean, and my grandparents, they never liked to go to the doctor. If you have a cold, they send you out in the bush to pick up a bush, you know? If you have anything that happens to you, my grandfather said, go to the street, get 2 leaves there, go, you know, and they believe in that herb, the natural herb, and it works. So you find a lot of people, they come to the United States, the grandparents are here, the parents are there, and whatever that they knew from back home, they bring it back, they bring it with them. So sometimes if there is an issue, one week, because I think the topic is most dealing with maternal health. And if there's an issue with a loved one in the home, and there is fear of being deported, or fear, here, I don't have the money to pay for the doctor when they send me this bill, I don't have the money. Whatever that they knew from home when it comes to herbal medication, herbal medicine, that's what they use. And sometimes it's not always, the right path to go. And another thing that I think that takes our community as well is using our people, our Black women, for guinea pigs. And I had my issues. I had 2 miscarriages. My first miscarriage, the fetus was in my womb for a whole week, dead, and I didn't know. I didn't know about it. I went to I delivered the baby at home, went to the hospital and then or the clinic, and they said, hey, the baby was dead. And then they said, well, the placenta, I don't want to be too gruesome, but I have to be real so people could understand the play, what we are going through and what our young mothers are going through now. Because if I knew then what I know now, it would have been different. You understand? And there it is, when I went there, it's like, oh, well, we have to scoop out the placenta because you were so lucky, you could have been dead. But although you're telling me that I'm lucky that I could have been dead, but even after I left, there was never no follow-up. You never asked me to come back or make an appointment and say, okay, you come back in this 2 weeks or come back in this 3 weeks. So in the community, education is so important. We have to educate our young people. We have to educate our community, and then afterwards, my second pregnancy, I think that I was used as a guinea pig. So I use myself as an example because there it is, went to the hospital and one person will say, oh, no, you're not pregnant. Another person said, yes, you're pregnant. Another person said, oh, no, you're not pregnant. And I was just like a yo-yo because nobody could tell me what was happening. And eventually when I went, they said, oh, yes, you're pregnant. The baby's in the tube and we have to remove the baby. And then afterwards, years afterwards, I said, okay, I'm ready to have another child. And when I realized nothing was happening, went to fertility doctor, and he's like, did you sue the doctor who operated on you? I'm like, so for what? And he's like, they bullshit you. You cannot have another baby. There are so many scar tissues that you'll never have another child again. Do you know how that sounds to me? But I didn't know any better. I had nobody to educate me. I'm coming from the Caribbean here like everybody else, going to school and doing my stuff. I didn't know any better. And so I am so happy to see this young lady that had her passion for those 2 young panelists and the passion to be out there to educate the community. It is needed. It is so needed. In the Black community, it is so needed.
Thank you, Fran, for sharing that and just the incredible, I think power of your personal story, bringing that in, the fact that you're able to share that with everyone, it means a lot to me. Personally, it's very affecting to hear your words. And, it's also very brave because it's hard to, get online and you can only see just a couple of heads here up the top of the screen, but knowing that lots of people are taking in what you're saying, and that you are an incredible advocate through everything that you've experienced. So thank you. I want to ask each panelist to answer a final question, and then we'll begin transitioning to questions from the audience. So I'm going to ask Nellie to go first. I'd like to have us reflect on 1 or 2 action steps that you would really like to see the health department take on maternal health.
Okay. The first one would be to make all hospitals equal. This is very important to me. I also, like Fran, I live in a highly Caribbean area, which is Canarsie, and my family is from Jamaica. And where we are, not a lot of people choose to have their babies in the local hospitals. So for me personally, I went to NYU Medical. A lot of my friends who live around here, they contact me and they ask me, where did you go to have your baby? Because I went to NYU Medical. I went an entire hour away from my home because I wasn't confident in my local hospitals. So I think it's so important that we start to make hospitals equitable when it comes to taking care of Black women and their babies and pregnancy and all of that, because there's not a lot of confidence in these hospitals these days, especially coming from Canarsie and East New York. So that would be my first one. My second one would be, please just start listening to Black women, believe Black women, because it's so important that we are heard. It is so important that when we say something, when we feel something, no one can tell you how you feel, but you can tell others how you feel. And so when someone is indicating that they feel a certain way, that something isn't right, believe them, investigate, and make sure that you have checked all of the boxes. It's so important. Those are my two.
Thank you, Nellie. Fran, let's go to you. 1 to 2 action steps that you'd like to see. Oh, she's just stepped away. Can you hear me, Fran?
Hi, can you hear me?
Yes.
Okay.
We're just reflecting before we move to Q&A on 1 or 2 action steps for the health department to take on maternal health specifically.
I think that educating health personnel is very, very important, because I know that Yvette Clark, when she came to the meeting, and that is one of the things that her bill was for, because at the time she took down some key information at the table dialogue that we were having, and then the bill came out, and one of them was implicit bias training. You know, and I so agree, because when we go to the clinics, we don't get the same treatment. We don't get the same service. I love to go to the regular clinics like everybody else, the city clinics. I like to go to like everybody else. And I sit and I watch. And it is not just a paycheck. The health facilities and health professionals, they're there to service, to heal. And if you go for service and you are sick and you're having some issues, and then when you get there, the treatment that you get, it's added salt to your injury. Because you are going to a place where you can get some solace, some place where you can get some comfort, you can get healing. But when you get there, the treatment that you get, and things that I've noticed at some of the clinics is that if, as Chanel said, okay, she's of Jamaican descent, she might be at the counter, or she might be servicing somebody who is from Jamaica. And they were like, oh, yes, you're from Jamaica. And they will speak the language and they will give you the best service. And then you'll find somebody who coming in from Guyana. And it's just not the same service. It's just like, oh, just go over there or go there. And people have to understand, you don't know who is who. So you don't know if Panamanian, you don't know where I'm from. So you have to treat people, and then you have to speak the language that everybody could understand. Because somebody will be sitting there, and the service you're giving to that person, you may be belittling that person in their own language, and you don't know. And it's things that I have seen happen. Even for me, because I'm a city worker, and I go to the clinic, they feel that I shouldn't be to the clinic. And the treatment that I would have received before they look into the system and they realize that I work for the city, It's too different. And it's ridiculous. And one time they said to me, so why are you here? Why shouldn't I be here? All the other people here, we are the same. You understand? And then you will find, and I gave you this scenario before, and it is not a good thing, but our other Caucasian sisters, and you have a Black sister, they will go to the same physician for the same ailment. They go and they said, you know, doc, however they want to address him, you know, my stomach is hurting me, I'm having this and I'm having that. And I'm telling you, it is not this say, it is experience that you will find that they will say, okay, go home, and what have you been doing? How is your diet? Have you been doing this? Go home, lay down, put and get some bed rest. But my Caucasian sister, the physician would say, okay, take your clothes, put on this gown, go inside, let me check you. And this Black sister is going home and have something going on in her body, and she was never checked. So by the time it's too late, you go to the hospital, is either something is wrong with the baby. It's not something that happens all the time, because I've been out there and there are some great physicians. There are some great nurses, but I'm telling you that there are some people, they're just in it just for the paycheck and not because they want to service people. So we need to educate, they need to be educated, they need to be trained, and to the word empathy, to learn the meaning of the word empathy, and to put themselves in somebody else's shoe. How would I want, if I was this person, how would I want to be treated? Would I want somebody to talk to me this way? Would I want to be treated that way? You know, we are all one, we are all human beings, and there shouldn't be one treatment for brown, one treatment for Black, one treatment for green. We all should get the same treatment.
Thank you, Fran. And I want to give you an opportunity to answer this question, and then we will be transitioning to audience question and answer.
Yes, to piggyback off of what Francesca was saying, and also Nellie, I'm for one like to kind of go back a little bit into the actual person, the one who's administering the service. What is wrong with them as to why their actions cause the demise of the patient, right? So what is causing the doctor to make these decisions, right? So we need to train the doctors, the administrators, like a whole reprogramming of this implicit bias, because we don't know where this implicit bias come from with them, but we know that the choices that they make are reflected on the implicit bias they have on the actual patient. So I feel like the doctors, what the Department of Health can do is do like a desensitization and resensitization type of training of doctors and administrative to give them the empathy that they lack for Black women, right? Because there's some type of empathy through a trigger as to why they wouldn't equally give the same care to a white woman than a Black woman. Why would the care be different, or their actions would be different? We're both pregnant that's the specialty you pick up, but then there's certain actions that you wouldn't do for me than you do for that other woman. Why would you do that, right? So either we weaponize these women with actual tools to make that doctor accountable, even when he's trying to use implicit bias on her. So she's gonna come in with what we're doing with at Birth Justice Defenders is with our standards, right? So we need to weaponize our women who are coming into these clinics with already doctors who already have implicit bias already in their heart. So we're gonna fight fire with these women. We're gonna educate them, equip them with the knowledge that they should have to defend themselves when they come into that doctor's office. We have to weaponize these women again to defend themselves. It's not like educate themselves. It's to defend themselves when they go into the doctor's office. Because even to a woman's better judgment, an educated doctor would tell somebody about how she feels in her own body and disregard her feelings and tell her that's not what she's feeling. Knowing that you are a doctor and these are the type of symptoms you should hear from a pregnant woman, why should you dismiss the cries of a Black woman but accept the cries of another race? Why? Why would you do that? So I feel like there should be more education, like a cultural diversity training for people in the community to learn about other cultures who may go through their birthing experience a little bit differently than the American way. Because they are here. These people are here. They're living in this country, and they are birthing here. So the way that they birth should be equal. It should be fair. And weaponizing our women in these instances would give them confidence. We need these women to be confident. When they step into the door, they should be already confident that when they speak to their doctor, it should be their equal, not an unequal. That's an equal because I'm getting a service from this doctor. So why should I be getting a disservice from a doctor I'm looking for service to? So we need to come in and weaponize our women with certain things to make the doctor and administrators, the nurses, everybody who's involved in this woman's birthing experience accountable, so that this woman can come out of the hospital post a year, because the instances of women passing away is within a year, past year 1, past year 2. We need these women to continue to live and thrive and continue to educate and weaponize herself with the tools that she's supposed to have. She should not have it, and it should not be kept secret. I think that's the problem when we talk about communication, that they use the English in a way as a way to not educate people who English is not their first language. So if you continue to put out messages in English or under a westernized English language, how is somebody who's not under a westernized English language supposed to relay that information? So again, we all have to come back to communication, training, proper training, proper communication. Get these people empathetic. More women coming out there. I want more women to come out there and show these stories to these doctors of what they do to them. I feel like they disconnect because once they step out the office, it's their life. But they need to hear these actual stories. Women who are out there listening, this is the reason why we want these doctors, these administrators to be empathetic, because they don't hear your stories. After you leave the doctor's office, they don't hear from you again. And they forget about you like you were nothing. And they continue to be unempathetic about you. So you now need to go in your community and strengthen your community members now, because you're going to say, listen, this is what's been secret, but my sister is gone. My friend is gone. These women are missing in your community and no one is saying anything about it. These women are constantly being missing on the thousands. If you see the numbers and the statistics, it's in the thousands. You don't see that face anymore and no one is saying anything. Nothing. And these are women, these are the vessels that are carrying our future, are missing. These are the vessels that no longer can produce another Black child because she's gone. So why is there no call to action about our lives being gone, right? So now we need to stop being secret as if it's like a secret to talk about our pain. No, we don't have to be what they stereotypically say, an angry Black woman. No, we are crying because it's a hurt that no one is sitting there understanding how we feel. It's just a simple understanding. We just want people to be empathetic. We don't, empathetic that this is actually happening to us and this is very real. Among other things, I am a woman. Before I am Black, I am a woman. When I was in my mother's stomach, it came XX, I'm a woman, first thing before anything. So I'm empathetic to every single woman out there, right? But then also I am phenotypically, I'm a Black woman. So I have this experience of being a woman and a Black woman. And I see what goes on out there. And I was ignorant to what was going on in my community until my friend Suzette Jules Jack told me what was going on. And I joined Birth Justice Offenders for that very reason. Because here I am ignorant in East New York, and we have the highest numbers of Black women passing away. And I'm here, living here for 30 years, and I didn't even know that. And this is my community. So now I'm responsible now, because if you don't know better, you do better now, right? So now I'm gonna do better. I'm a community member, and this is something that I wanna share because I have lived experiences. I'm a mother, I've been through pain, regardless of me being a mother. I've been in a hospital and being told that I don't feel my own pain in a hospital, telling me I can't get pain medications because I don't feel what I feel. I'm lying, right? But I'm in pain in a hospital. Like I want to sit in your hospital and sit in pain. So I know how a doctor can unvalidate you in an instant to make you feel small in an instant, and you can't do any better. But no, that's not going to happen anymore, because now when you walk into a hospital, you cannot say, well, I didn't know. You're going to know because our standards come in 7 different languages. It comes in English, it comes in Bengali, it comes in Spanish, Haitian, Creole, Arabic, simple Chinese, traditional Chinese, and maybe possibly many more. Because just like what Francesca said, there's a lot of instances where women who are immigrants who coming in, who are not getting the information given to them because the language, the way how it's given to them, you know, how are they to understand and reciprocate that when their culture is totally different from the westernized culture where now they have assimilated to. So I feel like educating of both the administrators, including the doctors, nurses, I don't care whatever race you are, because implicit bias happen amongst Black people too in the hospital.
Yeah.
Okay.
Yeah.
Nurses do it. The other people do it. So it's not only the doctors who are doing it, it's also the nurses who have now learned a behavior based on watching their superiors do this to other women. Learned behavior by just watching somebody do implicit bias. These people are learning this behavior and think it's acceptable for them to do it as well. And shame on them as well. Shame on them as well. So everybody has to be accountable, everyone. And they have to be retrained. From before medical school, there should be one of the classes you take while in medical school, some type of psychology training. We're in a new world now where everybody is mixed. You're gonna experience another Black, Spanish, or white person next to you real quick than 50 years ago. Now we're mingling with more people, so you need to be more sensitive about the community that you're gonna interact with. And I feel like it's not happening because it's like, oh, I become a doctor. You put you right back in the field. You're going to get all your field training while you're in the ER. That is not you learning your community. If you're going to be in an emergency hospital in the community, but yet you're from the suburbs, how are you connecting to that patient? You don't even know how they act, who they are. You've just been thrown into the mix. So who's training these people for cultural diversity? No one's really telling them, because you're throwing them in the field without letting these doctors be aware of who they're working with. So psychology training, empathy training, all these different things to deprogram these doctors who are already coming in before they even become a doctor, already have implicit bias about the opposite race. We're not talking about doctors who are doctors with implicit bias. We're talking about a person who has implicit bias in their heart, who every time they see a person of color, their decision is based on their bias, regardless if they're a doctor. So if they're a doctor and have this implicit bias, that means that every decision they make is biased. So we need to change that behavior with that doctor by either making him accountable, him or her accountable, by having certain laws put in place, by calling on your senators and congressmen and community members who do things politically, to create laws for hospitals, for public policy, for things not like this to happen. Because man is fireable. You can't trust man. That's why we have laws, to make sure that they don't do things they're not supposed to do. So one, education through doctors and the community. Also, with Birth Justice Defenders now, we're trying to do a podcast. So now more people can share their stories on a more intimate level, right? Because that's the new wave now with podcasting, more of an intimate way of communicating with people. So those are the things I would like to see with the Department of Health do: desensitization training, implicit bias training, and utilizing the tools, the standards that the Department of Health have.
Thank you so much, Anne. That was incredible. And I'd like to.
Before you go on, Sharon, not Sharon, sorry, Hannah. I know that you're about to go into question and answers, but I just want to read this, which is part of the bill that was passed by Yvette Clarke, if that's okay with you. And together, Congresswoman Adams and Yvette Clarke says our nation's current health system is failing Black mothers and their children. The maternal mortality epidemic in African American community has reached crisis level and continue to deprive communities of mothers, daughters, sisters, friends, and leaders, as long as mothers of color continue to suffer from disproportionate rate of mortality and morbidity compared to their white counterparts. The Maternal Care Act will help save lives. Women of color continue to suffer from implicit bias, a lack of adequate healthcare service, and desperate access to cultural competent maternal health education. And Yvette Clarke says maternal morbidity is a woman's health issue. As with all health disparities, women of color, especially Black women, are most impacted. Our country is the only developed nation in the world where the rate of women dying during childbirth are rising. American women are 5 times more likely to die during childbirth than British women, and we rank last among our global peers in maternal health and mortality. So I'm so thankful for my sister, for her motivation in going out there and fighting the fight. I'm with you, sister. I'm on board.
I'd like to thank you all for your contributions today. You're all doing incredible work. I think what I'd like to suggest, given the time, is that we have you each engage in the chat feature with anyone that has specific questions. And if you're comfortable doing so, you can exchange email addresses so that people can follow up with you directly. I'm going to turn it over back to Hannah Searing now, who is going to introduce our final speaker for the day. And again, thank you for the work that you're doing and the contributions you made to this event. It was really incredible to have you all. So thank you.
You're welcome.
Thank you. Thank you, Hannah. Thank you, Anne. Thank you, Fran. Thank you, Nellie. That was amazing. I mean, really, that was like, I feel like we reached a crescendo in the day. Like that just felt like this wave of just much needed voices that you were able to bring up and bring forth. And I just really, really appreciate that end to the day. We really needed that energy and your voices. So thank you so much. I want to thank all the panelists and moderators for this enriching day. Again, we want to acknowledge that there are a lot of feelings and emotions that will have come forth from people today. And we do have this red tent at the end of the day, which you'll hear more about. So as we come to the end of the day, we wanted to give voice to and space to another very powerful advocate. I'd like to bring her up to the forefront. I think I just saw her and now she's disappeared. But she is our last presenter. She is Miss Shawnee Benton Gibson, and she's going to lead us in wrapping up our day and having a call to action, because we've heard all these stories and all this data, and we need to come together and have a discussion about what can we do to address these unjust disparities and stories and information that we've been talking about today. So Ms. Shawnee Benton Gibson, here she is the CEO of Spirit of a Woman Leadership Development Institute, a boutique consulting firm whose mission is to educate, elevate, and affect positive and sustainable transformation in the lives of individuals, groups, families, and communities. She is the co-founder of the Foundation for the Advancement of Reproductive Innovation through Artistry and Healing, which was co-created in partnership with her son-in-law in memory of her eldest daughter, Shamini Makeba Gibson. Shamini passed away on October 6th, 2019, 14 days after giving birth to her second child, due to complications associated with having a cesarean birth. Ms. Benton Gibson is a licensed clinician, author, healer, spiritual leader, and reproductive justice advocate and activist who has devoted her time, energy, and resources and spirit to addressing the epidemic of maternal morbidity and mortality in communities of color. So with that, I give it to you, Shawnee.
Thank you so much. Greetings to all who have moved through this day with us, staying with intentionality and with purpose so that you can garner new information or recalibrate information that you already were aware of so that you can advance this conversation and mitigate or abolish this issue of maternal mortality and morbidity so that our lives as Black and Brown women on the planet, our children, the children who are being cared for in the community after a mother passes away, because there is something what we call in my work with ARIA, the foundation that my son-in-law and I co-created, what we call an aftershock. There's the big quake, which is the near-death experience, or the actual death experience, which my eldest daughter, Shamani Makipa Gibson, experienced after giving birth to her son 14 days after succumbed to a pulmonary embolism, a birth-related pulmonary embolism. And I say that emphatically because sometimes medical professionals try to say something different. And it's so important for us to know that that aftershock impacts everybody who is in this space listening, and those you are connected to, and those who are not in the space today. So I am honored to be in this space to share with you. And then also, I was asked to engage in a call to action, but the panel that just preceded this share from me already laid it out in all the panels that came before them. And so I'm like, what can I say that has not already been said? This journey has been something. Now, one of the things that I got profoundly connected to is that no matter how much knowledge I had, no matter how much I knew as a reproductive justice activist and advocate, because I was that before my daughter transitioned, no matter how much I knew as a clinician and as a community member, my daughter still passed away. No matter how much she knew, the quality of her education, having a doula for both pregnancies and having a midwife or a set of midwives for the first one, and then a midwife that was a community midwife of color for the second one. No matter how much coverage she had, no matter how much knowledge she had, no matter how much research she did, she still transitioned. And so first I was shocked. You know, of course, on October 6th, when my daughter first transitioned, I was shocked. Like, my daughter, this cannot be. And then I had to regroup and recognize that my daughter is a Black woman, or was a Black woman, and why wouldn't she, right? If, as was mentioned, Beyonce and others with means, if Serena could almost die as a result of giving birth or complications associated with it, why wouldn't Shamani Makipa Gibson? And then I had to get my mind right and get back on the mantle, or pick it up, so that I could continue this journey of transforming these outcomes for Black and Brown people and communities. So what I want to say to each and every one of you is that this is not contrary to what has been said. This is an addition. There was a conversation about diversity that was necessary for all institutions to engage in, and not all were. Like, it was they elected to do it or not. Then following that conversation, as the conversation about racism started to amplify, there was a conversation about implicit bias. I'm telling you, those two conversations are not enough. My conversation and my call to action, or my charge to each and every one of you, if you are a reproductive worker specialist, if you're a part of this movement, if you're a doctor or a nurse, or somebody that's a part of the community who is interested in all of this, or someone who has lost someone or had a near-death experience yourself, my charge is that you start to have conversations about racism, anti-Black racism specifically. That's my call to you, that we start using the language white supremacy in these conversations, because if we do not, then we'll miss the mark, and more women will die, more babies will die, or more near-death experiences will happen. So I encourage you to do that. What was said in the panel just before I came on was the necessity to start teaching medical professionals in medical school. I agree with that. But I also add that as part of a rite of passage for a young person, They should be in school learning about how these bodies work, and especially in Black and Brown communities, in communities of color or marginalized communities, they need to learn about this issue, this scourge, and learn about the proper names for their body parts, how reproductive organs work and their reproductive health works, and how they can actually be empowered and have agency and capacity to speak up for themselves at a tender age of 12, 13, 14, because that's going to save lives. I know I did not have that information. So when I did have my first two children, the first one, no one talked to me about my well-being. And so I had postpartum depression. And then the second one, I had a near-death experience. My daughter was preterm, and then also she had a birth defect, and she was born in the 7th month. And the doctor that was treating me was more concerned about how much my amniotic fluid was coming out of me and damaging her shoes than she was concerned about me and my baby. And this has been going on and will continue to go on. I have a grandbaby that's now 3 years old, and my concern, and it was mentioned earlier, that she will have to deal with this if we don't do what we need to do. So my charge is that we begin to stop clutching our pearls when people use the terminology racism, and that we begin to embrace and understand that we are all part of this insidious scourge called whiteness. Whiteness as a construct, whiteness as a political system that impacts, so that we can begin to learn how to undo racism, so that we can save lives and transform the outcomes across groups, but specifically for the groups that we're speaking about today, Black and Brown people. It was mentioned earlier about the standard of care. So when I think about the standard of care, I think about how everyone receives care. We know from this conversation that the standard of care did not work for Shamani Makiba Gibson, did not work for Kira Johnson, did not work for Amber Isaacs. So what we need is to employ some of the things that were mentioned by the panelists earlier to ensure that the care that is provided to folks who are in the most danger is amplified to meet their needs. So we're talking about trauma-informed care. We're talking about culturally relevant and responsible care for the clients, the patients, the consumers that we are providing services to. And that means as they're pre-conception, when they're carrying their babies, and after they give birth. And as we know, you can have an experience of near death or actual death up until a year after you've given birth to your child. So we need to embody, and you're going to learn about this if you choose to, the red tent practices where mothers are cared for in a way that is humanistic. And we need more physicians and caregivers to adopt a highly humanistic approach to providing care, talking with patients like you really want to know them, looking them in the eye, asking them how they're doing for that day, not just about what's happening with their physical bodies, but just how many other children do you have? What are their names? What's important to you? Because you have to co-create with those you are serving. I just had a colonoscopy. I'm a 52-year-old woman, so that's part of the necessity for me to live life and make sure that I am well. The anesthesiologist asked me if it was okay for him to say a word of prayer before he put me under. I was blown away, but that's a humanistic approach. And I could have said yes. He said, is it okay? I'm not asking you what you believe in. Is it okay if I cover us both? We co-create with those who we are charged to serve. As a therapist, as a clinician, as a healer, I don't do anything unless you are partnering with me and there's a synergy and an alignment. So anybody who has the arrogance to believe that because they have a set number of degrees or a certain level of knowledge or years in the field, who thinks that they can approach this without the support and the synergistic co-creation with the person that they're charged to serve is grossly mistaken. Doulas. Let's talk about doulas and midwives. I have so many in my life, and I'm blessed. I'm privileged to know a lot of them. And I'm privileged. I wasn't privileged when I was pregnant to have them, but I'm privileged to know them now inside of my reproductive work and activism and advocacy. But what I will say is that they need a living wage. You need a doula that is able to care for herself or himself, because I know male doulas, and their families, so that when they show up for you, they're rested and well, and they can serve you at their best. You need midwives of color in the field who are not worried about the oppressive nature of student loans because they owe so much money that they have to pay all of this money out. By the time the end of the month comes, they have nothing left to really provide for them and live quality of life. So what about loan forgiveness for those who are serving the community in the ways that are actually saving lives? What about making sure that we engage in a campaign to bring more Black midwives and brown midwives into the work in the conversation so that we don't have to depend on a handful and they get overburdened and then they're tired and not able to show up at their best. These are things that lead to outcomes that don't serve our communities. We also need to be training and developing folks about whiteness. This is a river conversation, not a pond conversation. What do I mean by that? It's a constantly evolving conversation. So just because you took a workshop 10 years ago about diversity and inclusion doesn't mean that what you learned then is relevant for right now and who you're serving in the community. Whether you're an activist, an advocate, a doctor, a nurse, a midwife, a doula, you need to be constantly studying and evolving your language and your understanding of what the issue is, studying the data with a bias or racially informed lens or anti-racist lens so that you can make a difference for the here and now, because it's now 5 o'clock on Tuesday, December 8th, and tomorrow the language may transform, the data may change, and you need to stay current and relevant to be responsible and accountable for this work. The movement existed way before now. So women, Black women, brown women who have been in this conversation about reproductive justice, study their works. Look up information about Audre Lorde, those who have been activists and advocates and been unapologetically in this conversation, revolutionary in this conversation. Study to show yourself approved and continue to do so that you'll grow. If you're a writer, write. If you're a speaker, speak. Make sure that the message is transferable. Teach the younger ones, because once we get tired, someone needs to carry this on. I hope it will be abolished and mitigated and we won't need this, but continue to teach the younger ones coming after you, those interns, those residents, so they know what they're doing and they can serve at their best. Today, we got so much beautiful knowledge, and I'll start to wrap up because I see that we're beyond the time that was allocated for this session. We were told about the biomedical approach that is just about the body and not the person. We were told about the moral surveillance, which is about judgment and not really dealing with the person's humanity. But patient-centered, trauma-informed, culturally relevant will transform the outcomes. It's less likely that a person will share with you what's going on with their body after they leave your office or the hospital or the clinic if you mistreated them. They're more likely, if you actually cared about them, to come back and say, I'm feeling a little bit shaky in my body and imbalanced. I feel I'm having racing thoughts, or I'm depressed, because unbeknownst to a lot of us, a woman can be counted as a statistic with maternal mortality if she takes her life within the first 12 months of after she's had a baby because she had severe postpartum depression or psychoses or mood disorder. Please stop nicknaming these issues. I mean no harm. We're calling it SMM, severe maternal mortality. Let's name it so that anybody hearing it knows exactly what it is. The nicknaming and the shorthand way in which we approach this doesn't work for a daughter like mine that passed away. Her name must be spoken. The issues must be said out loud. And shorthanding any of this is not going to support us as we continue to move forward. Oriana talked about brain. Asking the doctor about the benefits of a procedure. C-sections are pushed. The medicalization of birth is ridiculous. Somewhere, somehow, a man, probably a white man, declared that it was better and more economically advantageous for him to have women come into the hospital and give birth. And so the medicalization and the factory-oriented way of negotiating birth began, and then women stopped thinking about what they were feeling in their bodies and speaking that out and working with or trying to find a midwife to support them, and started to look towards men who don't have wombs, who don't understand how this works. And I'm not saying you can't be trained and developed, but they started to look towards the medical profession to dictate what was going on with them. And as a result, some of us have died or had near-death experiences. So benefits, risks, asking questions, using intuition, and asking for more time or needing more time to assess. Powerful. The last two things that I will say before I get off the line is we need the men in this conversation, those who identify as men, and also to recognize that everybody who is a person that gives birth identifies as a woman. So changing our conversation and recognizing that we need to expand our worldview and our paradigms that we use to negotiate this work. Men absolutely need to be present. They could be the activist, the advocate in the room with the woman while she's trying to give life and push out life and negotiate the space with the baby or babies that are trying to come through. My son-in-law and I are in this work together. What are the costs if you don't do it? Someone said in the chat earlier, it's very expensive. Practitioners don't want to take that on to sit with the patient longer, like you got to keep moving them through and you have to bill. I get that. But the cost to not doing it is that a woman is not here to help contribute to her family financially or to raise her children. And they have the fathers and the other family members or whomever the partner is has to scramble and figure that out. The community experiences the ripple effect, loss of skill set. My daughter had 2 businesses and now she's not here. 2 children not here to raise them. There's an impact that is beyond what we think on the surface or just the one-dimensional aspect of the conversation that we're often engaged in. We cannot afford not to. Finally, making support accessible for grassroots organizations. We must. When we write the RFPs for those of us who have access to that and create spaces for those to get money in the community, we must make the monies accessible. We must make sure that they have capacity to honor what is requested, and we must decolonize the way that we negotiate grants and all of this so that folks can actually understand what they're being asked to do and can deliver without stressing themselves out. These grassroots organizations, these community doulas and midwives, they need support, and we need not make it oppressive so that they can, so they can get the support that they need in dollars and cents. That's really important. I thank you for the time and the energy. I thank you for spending the day here. I honor you for being willing to negotiate this conversation, to have your belly flip and still stay in it. And I encourage you and charge you to continue to do that to save lives. Be blessed and be a blessing. And thank you very much for listening.
Wow. Thank you so much. Thank you. That was beautiful. So beautifully put. So wonderful to have you. We couldn't ask for a better person to have closed our day. Thank you so much for sharing that with us. I really, really, really touched me. Thank you.
Thank you,
Hannah. Before everyone leaves, I'd like to just have you a few housekeeping things. We have a summit survey. It'll help us if you fill it out to continue to improve providing events like these. The link will be emailed to all summit attendees and added to our chat box. The SMM toolkit, which you've heard about today, is available on the DOHMH website. Again, the link will be mailed to all of the attendees today and added to the chat box. We recorded all of this, and that also will be emailed within a week, and the recording on YouTube, so closed captioning can be enabled. And I want to acknowledge that we spoke in detail today about physically and emotionally traumatic experiences. We just ended with so much emotion, and we talked about childbirth and racism and white supremacy, and we need to just honor that. And as you heard today, we do have a space for people to address and close the day. Please use New York City WELL. It's a connection to free, confidential mental health support if you feel like you want to speak to a counselor via phone, text, or chat. You can get access to mental health and substance use services in more than 200 languages. And that's available 24/7, 365 days a year. The telephone number for that is 1-888 New York City WELL. And you can also text WELL, WELL, to 65173. Additionally, we're offering this red tent sacred circle for you to end your day, where you could share stories and release emotions as you wish. It will be conducted on a Zoom, another Zoom room in a separate space, and the Zoom details will be dropped in the chat box now. This space this idea for this space was conceived by the Spirit of a Woman Leadership Development Institute and has been used in other virtual spaces, such as the Mother Wit Conference, which Shawnee sponsors and organizes, which was a wonderful conference. The Safe Space is organized and led today by Ms. Yofu Limwenge, who is waiting now to share the space with you. Ms. Limwenge is a long recognized professional in advocacy for women's empowerment. She has touched hundreds of families with her passionate support of their birth and beyond experiences, with a focus on physical and emotional resilience. Kenyofu holds a bachelor's degree in community and human services and a master's degree in education. She has inspired generations of resilience from wombs to classrooms through social emotional projects, initiatives, and collaborations. Kenyofu serves the community as a coach, mentor, educator, and facilitator. And we've also dropped in the chat reproductiveawakening.com, which is where you can learn more about the Red Tent Sacred Circles, which she is going to hold for us in this other Zoom space. And you can also find out more about the lifetime impacts of childhood stress and adversity on the developing brain at www.fighttrauma.com. Thank you so much for your attendance. I honor everybody who's been here today, participating, listening, being with us. And please contact us with any follow-up questions or information. I wish you a wonderful evening and thank you again. Have a great night.